Senate Chamber. Signed. 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 Senate Chamber. signed, Senate chamber, 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 signed, Senate Chamber. Signed. 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 Senate Chamber. signed, Senate chamber, 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 signed, Senate Chamber. Signed. 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 Senate Chamber. signed, Senate chamber, 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 signed, Senate Chamber. Signed. 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 Senate Chamber. Sound. 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 Senate chamber. Sound.
Let's open the doors then. Welcome members to the concurrent meeting of the Committee for Justice and the Committee for Health. The meeting is now open to the public, and we'll pause for a second to allow people to take their seats. Members, please be advised that the committee will be recorded and broadcast throughout Parliament buildings and online. Those here in the public gallery are welcome to use mobile devices as long as they're in airplane mode and all devices are muted. And you can connect to Assembly Wi-Fi and password details are available in the gallery rules. Just a reminder that it's not permitted to take photographs or record any of the meeting. Members, the following members will be attending the meeting virtually. We currently have Stephen Dunn, Orlia Flynn and Sinead Ennis, and we're expecting Diane Dodds. Also, please note by way of apologies that Stephen Dunn will have to leave the meeting early. He's had a family bereavement and we express our condolences to you on that, Stephen. Members, it's proposed that the oral evidence session with the PSNI and the oral evidence session with the DOJ and DOH officials will be recorded by Hansard. Are you content with that?
Content.
Thank you. Agenda item 1 is apologies, and we have apologies from Doug Beattie. Are there any other apologies? Morris?
Yeah, I'll have to leave the meeting shortly after 4.
Thank you, Morris. No, nothing else. That's lovely. Thank you. Agenda item 2 is declaration of interests. Members, we're obliged to declare any financial or other relevant interests which might reasonably be thought by others to influence our approach to matters under consideration. Any members who have interests to declare in relation to today's business should do so now or when the particular matter arises in the meeting. Do members have any interest they wish to declare at this stage? Linda?
I'm not sure it's an interest, but I'm a member of the policing board, so rather than me having to say that every time I go to speak, just have that on the record.
I'm also a member of the policing board as well.
Thank you, Nuala. Can I declare that I have an immediate family member who works in the legal profession? Anybody else have anything? No?
Chair, I have an employee within my office who's a call handler.
Okay, thank you, Alan.
Actually, is there an issue on members of the policing board actually being here? Because members of the policing board aren't allowed to be members of the Justice Committee. Does that place them as a joint committee? Does that put them in any difficult position, given that... I'm trying to get rid of you. But just given that they're not permitted to be a member of a Justice Committee, but then in a joint committee, puts us in a double forum, but it does maybe...
I think that's, I presume, Colin, that that's with regard to the operational separation between policing matters and Department of Justice matters. I suppose in this circumstance, however, the police are just giving evidence with regard to a wider picture. So I see where you're coming from. I don't think so, but let me just check if officials have any view on that.
It is a concurrent meeting rather than a meeting of the Committee for Justice, Chair.
So I think in that regard we're all right. Yes? Yes.
I
Deirdre?
don't even know if it's an interest or not, but just to declare it's more the health end. I have an immediate family member who fosters, so I don't know if it is even a conflict, but just to say it.
Yeah, probably better to have it out there than discover later, and then there's no questions can be asked. Danny?
And I better declare I'm a registered nurse at the Ulster Hospital as well, on the nursing bank there. So
I better declare I'm on a career break from South Asian Trust for about 5 years now. But.
So essentially what we're saying is we all have an interest somewhere down the line.
I'm very interested
Everybody's
as
got an
well.
interest in policing and health on many levels. Okay, I think that's us covered. Thank you very much, everybody, for that. So agenda item 3 then, right care, right person, and we're about to hear evidence from the Police Service of Northern Ireland. I would remind you that the purpose of this concurrent committee is to take oral evidence on right care, right person and the operational model on that from the PSNI, and then we'll take oral evidence on the model and collaborative working from the Department of Justice and Department of Health officials. Members, the procedures for this concurrent committee are to be found in the clerk's memo, which is at pages 3 to 13 of your meeting pack. Can I ask you to note this memo? Yeah, thank you. And then with regard to the police's evidence, then I would ask you to refer to pages 14 to 34 of your meeting pack for the relevant papers. So with that, I will welcome Assistant Chief Constable Ryan Henderson, Chief Superintendent and Branch Head of the Justice Department, Gary MacDonald, and the Principal / Head of Justice Healthcare Branch, Una Williamson. So just folks, for you to note that this evidence session is going to be recorded by Hansard, and the transcript will be published on the committee's webpage. I presume that you're happy enough with that.
Absolutely.
Thank you. So I'm going to hand over to you to give your presentation, and then we'll take questions. We've organised ourselves with regard to questioning in terms of themes. So the types of questions we will be coming to you with following your presentation, there'll be issues around young people in care settings, issues around police attendance at A&E, some general questioning on statistics and some of the issues that have arisen from within your presentation. There'll be issues around the current status of the programme and the protocols and boundaries around that. Some further information required regarding statistics and fatalities, and some issues around vulnerable children and lessons to be learned. So that kind of gives you a rough idea as to where we're coming from, but we'll hand over to you now, Ryan, for you to take us through your presentation, and then we'll come to questions after that. Thank you.
Yeah, thank you, Chair. Thank you very much for your kind invitation to the committee today, and lovely to see you all. I'm really grateful for the opportunity to be in front of you today. I'm grateful actually for you taking the opportunity to shine a light on the very kind of pressing issue of the prevalence of mental health presentation within the justice system and the impact that has and how it manifests itself for the Police Service of Northern Ireland. I know you also want to hear about right care, right person and the opportunities that approach presents. And thank you for introducing the team. I'm going to do the talking to start with, and then we'll get into questions. The team will jump in as well in relation to that. So in thinking about what to say, I thought the best place to start was, I suppose, with the obvious question of just how much work do the Police Service of Northern Ireland do relating to members of the public who are suffering health or mental health crisis. The answer is that it's a hugely significant amount. Certainly clear to me, and I suppose clear to many of the committee if you've been to an emergency department, that policing's become baked very much into the everyday public sector response to unmet health demand, and that amount is at very unprecedented levels. I mean, I don't think it's unfair to say that the police service have become the emergency service of first resort for mental health crisis in Northern Ireland. I know if you were to talk to our call handlers or our frontline officers, they'd give you a very real insight into how overwhelming that has become in terms of volume. I suppose I would say that to some extent, for those of us who are very involved in this work would know, that would not be a surprise. Northern Ireland is acknowledged to suffer higher rates of common mental health problems, higher rates of psychosis, higher rates of addiction than similar sized populations. So whilst having said that may not be a surprise, I do think the public would be shocked and surprised at just the sheer scale and amount of time their police service is spending dealing with things that they would probably not consider, and I guess the committee probably would not consider to be police work. To help give you a better sense of that, I wanted to give you some data. I caveat that. So we're not a healthcare organisation. We don't have clinical governance. and our IT systems aren't designed to capture health-related data. They're set up to capture crime and incidents of that nature. But we do have some data, but because of all of the above I've said, it's very conservative. It's very low in terms of capturing the amount, but I think it's helpful in giving an indication as to the levels. So in the last 12 months, the PSNI have received in the region of 39,000 concern for safety calls. That's about 107 a day, there or thereabouts, over the last 12 months. This is a category which captures most of the incidents that we pass through from health partners or the public relating to what I think you'd best describe as well-being or safeguarding concerns. Only 3% of those relate to crime. So I think it's worth repeating that only 3% of that very significant number, that's a significant amount of police effort, actually relates to criminality. Probably in the region of about 1,000 out of that 39,000 over the course of the year. And those requests for police resources come from across a wide range of healthcare settings, including emergency departments, from wards, GPs, social services, mental health teams, etc. Some would send much more than others, so we get around 11,000 calls a year from the ambulance service control, probably about 30 a day, so very vast amounts just in terms of the quantity of that. And whilst we've got a good idea around the volume, one of the things we've hitherto struggled to get a handle on is just how much time that takes, or how much police time is spent dealing with all of that health-related demand. And we know from our frontline staff that time spent waiting in people's homes or emergency departments, waiting for them to be assessed by appropriate health professionals, is significant. So in order to kind of collectively help us with some baselining around that, we commissioned a data collection survey covering a 28-day period from Monday the 10th of June through to Sunday the 7th of July 2024. During that period, we asked officers to complete an online questionnaire regarding details of their deployment to a range of vulnerability and health-related incidents. So these included, in fact this was exclusively walking out from healthcare settings, concern for safety calls, mental health detention calls, transportation of people in health crisis, and voluntary mental health patients, dealing with people who we have taken to the hospital voluntarily rather than detaining them, with some concerns around mental health. We're able to take that data and extrapolate it to give us, I guess, a good sense of over a year what that might build up to. Over that 4-week period, there were at least, and I'll explain why I say at least, 8,142 officer hours spent responding to those types of calls. That scales up to well over 100,000 hours of police time per year spent dealing with those types of calls. And if you want to put a cost to it in terms of opportunity costs, that's in the region of pounds and pence of about £4 million worth of police officer time spent dealing with those concerned for safety incidents. A staggering amount, I'm sure you'll agree. And time spent waiting in hospitals, unsurprisingly, makes a significant part of that time. During that 4-week period, on average, when waiting for assessments in the emergency department, the waiting time for officers with the member of the public was 13 hours and 59 minutes. That was the kind of average time that police would be waiting for assessment. In that 4-week period, that accounted to about 2,535 hours of police time, around north of 30,000 over the year, and probably around £1 million worth of police officer time spent waiting for those assessments to take place. So they are pretty staggering numbers, and I think it gives you a good sense just of how much of police time is spent on that. And I want to stress to you again, that figure is really conservative. It does not include the additional officers who initially responded to the incident. So often you'll get 3, 4 and 5 may go, but 2 would typically remain with them in hospital, or the time spent by our call handlers. So clearly the first place this comes into is our call centres, and there will be a process for doing background checks, checking data, and doing an assessment in terms of the risks from that. So we haven't been able to capture that within that process, but which is why I say to you it is conservative. Well, what does all of that mean? I mean, for me, I guess the impacts are threefold in this. Firstly, and most importantly, this is not right for those members of the public who are in health crisis. I don't think there's anyone who thinks that having a police officer with their gun, their stab-proof vest, their handcuffs should be the mental health support for someone in health crisis for significant periods of time. I don't think anyone thinks that is right. It's hugely stigmatising and traumatising for someone in need of health care that they are sat in the emergency department surrounded by police officers whilst they await an assessment. Officers who are not and never will be appropriately trained to deal with their needs. Or likewise, if after a call from a GP, the person is sat in their home with a police officer inside and a police car outside awaiting the appropriate health professional to arrive. That does not happen if you have a broken leg, but yet it can if you have issues with your mental health. In effect, we are criminalising mental health. Secondly, it's putting police officers in a really difficult space and a difficult legal place. We're not a healthcare organisation, as I said, and we don't have the clinical governance and decision making to support some of the decisions police officers are having to make. And their accountability for their decision making is through the Office of the Police Ombudsman, a criminal justice ombudsman, not a health one. And we're asking them to make clinical judgments about a person's mental well-being and then detaining them as a result. And they do that against the backdrop of concern that if they get the judgment, which is in essence a healthcare judgment, wrong, then they'll end up under investigation for a decision that they were not properly equipped or trained to make. Add into that the significant amount of time and the cyclical nature of how often they are dealing with individuals who are in need of healthcare repeatedly. And very importantly, I can't stress this enough, it's not right for our community. Less police availability means less policing. And our communities need their police service to be focused upon policing, more now than ever. The financial pressure facing policing has been well reported, but it bears repeating. Today we sit with the lowest number of officers since the PSNI came to be. Today we sit with half of the neighbourhood policing teams we had 3 years ago, and our communities are feeling the draft. It feels that the threats to our community are becoming ever more challenging. 4 women murdered in a 6-week period since August at the hands of men. Race hate riots in the summer. The awful the catfish case. The continued shadow of paramilitarism and the criminal exploitation of young people. That is police work. That is protecting our communities from harm. And policing is critical. It is the part of the critical infrastructure for Northern Ireland, and it's in all our interests that we work collectively to refocus our police on police work. So why is right care, right person important, and what opportunities might it offer? I think probably really important, the first thing to say is what it's not. So this is not the Police Service of Northern Ireland walking away from all mental health calls, far from it. There are and will continue to be concern for safety calls related to mental health where the police will of course still attend. Those instances where a person's in crisis, posing a real and immediate risk of harm to themselves or others. We have the powers, the equipment, the skills, the lawful authority to deal with incidents of that type. All day and every day we will continue to do that. There is a very valid conversation to be had about how long it then takes for the handover process. We've talked about some of those waiting times to get that person in need of crisis into the appropriate medical care after we have dealt with the initial risk. But we will go and we will continue to go. However, beyond that, there is a large chunk of much more routine, unmet healthcare demand and need that has no imminent risk of causing serious harm, that passes to policing. And this is where we should start to focus this work. This is the starting point, being that when people with health needs need first and foremost the care of trained health professionals. And it is there and in those calls that policing have been baked into going to, that we see the focus of right care, right person starting. Right care, right person, just by way of reminder for those who may not know, it's a national programme in England and Wales, signed up to by 43 police services and health partnerships across England and Wales. The aim being to ensure that individuals in health crisis are seen by the right professional. It's now recognised as best practice by the College of Policing, and really importantly, and it has been so important that it has had national governmental support through Westminster in terms of giving that strategic support to the Department of Health and others to right care, right person. I think the great thing about the fact we are coming to this much later than others is that collectively as a system, and we are a system, and I see myself as part of that system, but a system of health and justice professionals, we can take all of that best practice to understand what works and what doesn't. And we are well connected into those overarching cross-departmental governance processes in England and Wales that have coordinated right care, right person as it's developed. Broadly, right care, right person has focused upon 4 key interface points, and I think you'll recognise these from the data that I've given you, and you'll kind of understand why. So the first of those is those concern for safety calls, the 39,000 that I had mentioned to you annually. The second being the walkouts from healthcare settings, not exclusively emergency departments, but any healthcare setting. The issue of transportation and conveyancing, so if the ambulance don't feel they can take someone, then do the police step in to that and in what way? And then lastly, detentions under Article 130 and voluntary attenders. So for those that aren't aware what the legislation says, but that somebody's in a public place and the police are with them and we assess that they need assessment, we are then given a power to detain them. The place of safety that the legislation says they have to go to is the emergency department. They will then be assessed, but the people who assess them aren't forward based in emergency departments, and often that is then leading to the delay. It's a capacity issue within health settings. So looking at, and there are alternative approaches to this, is an important part of some of the right care, right person developments. And there are significant benefits being realised through right care, right person across England and Wales. I think it's worth highlighting a few of those to give you a sense of that. And again, it's the great thing of coming to this slightly more later, and we can see where it's starting to bed in. So Humberside, where this started, police there are reporting a reduction on average of 508 deployments a month, equating to a significant saving in officer hours, saying that the calls have dropped from partners from 35% to about 16%. In North Yorkshire, they've seen their compliance time for calls we're able to attend going up from 67% to 83% over 12 months. Bedfordshire likewise showing an improvement in the time taken for them to get to domestic abuse calls. I think really interesting in the Met, having in the region of about 20% less calls that they were going to, about 6,000 less. They are getting to robberies 18% quicker than they were. They're getting to more robberies, they're getting through them more quickly. And importantly, they're spending 21% more time, they assess, with victims of crime. So you can see for the community and for victims some real significant benefit by ensuring that people who are vulnerable are getting the right support. I've been really clear from day one when I've been thinking about right care, right person, that at the heart of any planning the focus has to be those people in health crisis, ensuring that patient safety is paramount and they're not left without support. This means the approach to implementation has to be planned and developed jointly through cross-agency partnerships before changes to responses are introduced. It must be done collaboratively with our colleagues in healthcare. I guess to support that, over the last 9 months, I've been engaged extensively across the health sector to try and develop the necessary kind of collective recognition of the issues and to start conversations around right care, right person. I've met with the Royal Colleges, the Mental Health Champion, the Victims Commissioner, the Children's Commissioner, and a broad range of strategic leaders across health trusts and the Department of Health. I'm sure they're absolutely fed up of hearing from me. But those conversations have been very positive. Constructive, open, helpful, in the spirit of better understanding and partnership. And to a person, they agree that change must happen. They agree that it's not right that policing has become so involved in dealing with health demand, and indeed they are often shocked when they learn just how extensive that demand is. That said, for some there's the understandable intake of breath by what that might mean, the concern about that, what that might mean for their part of the healthcare system. And that's a really valid question, and one I'm really keen to help to answer. I've always felt that whilst the demand is really significant for PSNI as the single point of receipt for this work, the demand comes from all across the health sector, and thereby not being hugely significant to the individual parts of it. Indeed, our deeper analysis of the data, we have included assesses a significant sample of calls against the principles of right care, right person, to give an indication of how that might work through in terms of those who we would attend and those we might not, and what that might mean for health partners. And a key next step, and that's a commitment that we have jointly, is that we're going to share that data with health colleagues so we can start to work through this together. I have to say that both departments, Health and Justice, have engaged very positively in a spirit of collaboration, and having spent time with both the Justice and Health Ministers and their teams, I'm delighted to report that the first cross-departmental Right Care, Right Person Oversight Group, jointly chaired by senior officials from both departments, has now been formed to support implementation of Right Care, Right Person for Northern Ireland, and we met as recently as last week to have the first of those meetings. This oversight group will help steer the work of an operational group, which Gary and Una are involved in, focused on the mechanics and process of delivery. This, for me, is a very encouraging step and feels like progress. Our starting point will be to use our data and that of health colleagues to map out a path for change. So in closing, I hope that my opening remarks have helped shine a light for you on the level of demand, what this means for individuals in a health crisis, our staff and the wider community. I hope also to have shown how Right Care, Right Person offers a new pathway to focus police officers on policing, whilst not in any way increasing risk to those with health vulnerabilities. I hope also that you're reassured by our and my desire to do this collaboratively with health colleagues, and that I am comforted that the steps both departments are taking are setting us in the path to deliver the required change. Thank you very much.
Gary, Una, do you have anything you need to add, or no? So we can just go straight to questions.
Good questions.
I'm going to turn first to the Chair of the Health Committee, please.
Thank you, Chair, and thank you, Ryan, for your very comprehensive opening remarks. I think it's a very important meeting, and I think it's good to see the overlap between both departments and how we can try and improve that going forward. I suppose just to start off with an issue which not directly related to a mental health case, but in my own constituency in Uri, we saw the death of a young woman on the street in Uri because ambulance couldn't come, police were called, obviously couldn't take her, and sadly that young woman passed away, which should never, it should never have come to that stage, but it shone a light on the real issues in terms of resources, but also where PSNI are being called out to inappropriate situations. So I suppose based on that as well, I would be keen to hear from you, Ryan, and others, just the kind of response, the feedback you're getting from colleagues in Department of Health where these situations are arising. I mean, some of the figures you've quoted there are huge and would most definitely be better used elsewhere in terms of the work of the police. So it'd be good to get a sense of that. And secondly, then, in relation to the huge numbers of calls to children's homes, to deal with mental health incidents. I mean, has this approach then been directly influenced by that and police being called to really, really complex and challenging situations? Because I'm also very conscious then on the impact on those children and young people who potentially end up with criminal records as a result. So there's just my first two, and then I have one more, and that'll be me.
Absolutely. Thanks very much. I'll start and say a few words, and then I'll pass to colleagues, particularly around the very important issue around young people. I suppose just reflecting in terms of the support from the Department of Health, and certainly we're really seeing that now with having the governance in place. I suppose initially as I was starting the conversations, and some of this has probably been around me finding my way within what is a really huge infrastructure of health. So I have, I suppose Gary, Una and I, both from the background of having worked in public protection, and Una's worked in the justice healthcare world for a lot of time, so we have a lot of very good contacts within health, particularly operationally within trust and leadership roles. So I've kind of lent into that quite heavily. To be able to get these conversations up and running and off the ground, particularly with the Royal Colleges and others, who, as I say, have been very supportive. The mental health champions have been very supportive as well and engaged in those conversations. I think that's been really good, and that got a kind of a groundswell of movement around it and a recognition of the issues. That, I then think, brought itself back into the department, where quite rightly people are then saying, so what will that mean for us? Should we kind of move along with policing now? Where will we get the coordination for this? And the department, in recognising that, have kind of stepped up in the sense of understanding they have a role in helping to coordinate that. But I understand as well that because it is a new and a different thing, and it's, Ryan as the ACC has been kind of raising it and talking to people about it, it might feel that it's something that people feel we're running towards without having done it in a properly consultative way, and then that's not me, for those that know me, and I want to do this together because at the heart of it I don't want any more risk to people who are in crisis. So I think the department have kind of understood where they fit into that and have been now working to bring all of that together, supported by the Department of Justice and the new governance group. So I feel, I'm an impatient person, sadly. So we've been talking probably for 9 to 12 months to try and start to get that sort of shift in that coordination. I think we've got there now, and actually in the talking and in the conversations, it's been a brilliant way to kind of understand maybe some of the consequences that we wouldn't necessarily have thought about. It's also been good to allow us to get that learning nationally, and I think now we've got ourselves into a good place around it. The key is let's start doing, because it is an area we could talk strategy about all day long, but actually, and you've heard from the data, I feel there are some really operational things that we can do collectively as public sector partners to help understand a bit more about our roles and who's best to be dealing with certain things that can make progress around some of these important issues quite quickly, and I think we're getting in a good space to be able to do that. And maybe bring Gary and the others in around the really important issue of young people. So I guess my starting point is young people deserve the right care as well, and I don't think the right care for a young person when they are in a crisis in a healthcare setting, that the first call is to the police, because we're criminalising young people through it. I'm convinced of that. But Gary, maybe you want to talk more generally.
Yeah, I'll maybe touch upon the ambulance piece first before going on to the children's homes aspect. The ambulance service will be around the table at that tactical level in terms of the decision-making process, in terms of that demand and those calls coming into our control centre. So how we design those solutions, how we design that kind of referral pathway and that decision-making process, the ambulance are going to be key to that co-design process through Right Care, Right Person. In terms of the children's homes demand wasn't a specific driver for Right Care, Right Person. It's much broader than that in terms of mental health demand that's facing policing. In fact, from our recent data collection exercise, it was 2.6% of the demand came from children's homes. And I know that's also part of specific policies that have previously been agreed between PSNI and Health in terms of how we respond to issues within children's homes as well, and I think that's working quite well.
And the work around the Philomena programme, I think, is a really good example of how collectively you can get a better approach without increasing harm to young people in those settings, and that seems to be working really. Certainly we feel that that's working well in terms of reducing the number of times that police are having to be the first port of call around those.
It was just on the children's home piece. I think one of the articles stated that there was over 5,000 calls to children's homes, so that in itself is a particularly large figure. My only other question then is in relation to Chair, the Caudry case, which I know is referenced in the briefing, and we have as a party met with Charles Little recently enough, and the committee will be meeting some of him along with some of the other panel members too. I would just like to maybe hear your perspective on where things potentially went wrong in that case. I don't mean to go into the real detail of it, and we are across a lot of the detail of that specific case. But I suppose, given that we have Department of Health officials in today as well, it would be good to understand that maybe, because I know the police were involved with the individual on a number of occasions over a period of days there, and just what your view is on that and how things could have been done differently if the right person was dealing with him instead of it being a police matter.
Yeah, no, I'm very happy to talk about that. And we actually have been really closely involved as a team in the work post the inquest findings in relation to it. The coroner, and it's a fantastic judgment, I think, in terms of shining a light on where the kind of operational complexity and misunderstandings around the outdated policy and very different practices were at play were really brought out within it. I've met with the coroner a number of times myself, just in the immediate aftermath of the inquest, to get a much better understanding from her as to what the key issues were. And I think that has been really helpful in helping me and us as a team to start to address those. We also, and you will know, apologised very publicly but also very privately to the Caudry family in relation to Michael and Marjorie's deaths. We have been working really closely with Charles Little and the family in terms of how things can be done differently. Charles has been an incredible help to us, almost helping to advise Gary, Una and I personally around how we can address the issues, and has been a great source of strength to us incredibly as we kind of worked through it, and we're really grateful for them to do that. in essence, what the coroner said was she assessed the different incidents in the run-up, and I think it was 5 over 4 days, looked at what the guidance said, what the legislation said and what the GAIN guidance said, and then looked at what actual operational practice was and put the two together and said they are very different. And as a result made recommendations in relation to changing the guidance, developing training and developing better operational working arrangements. I kind of threw myself into it and immersed myself in it because I kind of wanted to understand why one was different to the other. And if anyone takes a walk into an emergency department, which is the place of safety designated within the legislation, I don't think any of us would necessarily feel that is the safest place for someone in mental health crisis with police officers to be taking them. And the reality is that they're incredibly busy places. And actually, operationally, how matters are dealt with varies greatly from ED to ED and even from shift to shift, because they're hugely busy places with various people working at different times. And what had happened quite significantly was that the operational practice, both on our side and on the ED side, had shifted a lot from what that guidance, which was written back in about 2014, said should happen, because operationally things are just very, very different. And actually, some of it for very good reasons, but the things were very different. I worked really close because I knew things had to change as a result of having met with the coroner, read the report. So met with colleagues in the Department of Justice, Department of Health, and said, look, this is the operational reality of this. We have got a duty to do something in terms of bringing change. And again, I think the departments both rose to the challenge and have brought together a working group, which has a whole series of groups within that are looking to refresh and redesign the guidance, looking to see how legislation could look differently and looking at operational training and practice. It's really tangibly, I think, will make things different and better. We've been able in the interim, in terms of our own staff, to be able to refine our guidance as well, to help give them much clarity about it. Una sits very much for me and leads on that work, so maybe invite Una in to talk a little bit about actually what that is delivering and when we hope to deliver it. But Charles, the family, are very closely involved in that. We've made a real point of making it very transparent so that they and others can see how we're taking that work forward, and I think that's been really, really good. And we pushed it because it was quite, at the start, it was very mental health focused, understandably, but actually much of this was about practice within emergency departments and the busyness of that. And actually this isn't about strategy, it's about getting your sleeves rolled up and understanding what operational practice looks like and how you can affect it across a range of settings, and that's what the work's trying to do. Una?
Okay, yeah, thank you. Yes, PSNI are very much involved in both the oversight task and finish group, which is chaired by Department of Health and Justice, but also, as Ryan was saying, within particularly work stream 2 and 3. Work stream 2 is focusing on the review of the mental health order, the GAIN guidance, the conveyance protocols, everything that relates to, and it was mentioned in the inquest. And that is, we're probably going to be reporting back collectively before Christmas in terms of recommendations on the way forward, which will feed in then to workstream 3, which will focus on collectively and collaboratively new training across frontline responders, including PSNI. So there is a lot of intense work has gone on over the past number of months. As you can appreciate, there's a lot of pieces of legislation and information to review, but it has been significantly moving at pace. But in the meantime, actually, as a service, we collaborated with the PHA to introduce mental health first aid training, and we rolled that out all frontline officers, but also other staff within Operational Support Department, within OHW, within other parts of the organisation. They have the opportunity to engage in mental health first aid training. It's a 2-day course. It's been funded by the PHA, and that has given us the opportunity to ensure that we try and close whatever gaps we see at the minute. The take-up across the organisation has been phenomenal, and equally the feedback on the actual training has also been excellent. So it's something that we're continuing to partner with. And we will feed that in probably to Workstream 3 within the Quadri task and finish group. But that's certainly from our perspective, I think it's given us an opportunity to engage with our people around, first aid training and what they should be doing in relation to dealing with people in mental health crisis.
Okay, I know that Linda's got a brief question on this one. Members, I'm conscious that we do have quite a considerable list, so I would aim that I want people to be able to ask the questions and follow their train of thought. So if we can aim to keep preamble to a minimum and keep everything as succinct as possible, I think that'll be helpful, just to make sure we can tease out as much as we need to tease out and follow through our trains of thought. Thank you, Linda.
I'd be glad to hear this is the only question I'm asking you, because I get plenty of opportunity in the policing board, but it's probably yourself. Just in relation to, you're saying work has already started and PSNI are doing work, but it is my experience, and this is direct experience in the office, that people, whenever the PSNI are bringing them to A&E with serious psychotic episodes, that they're being released. I had one occasion where PSNI ended up having to arrest them, ask the family could they tell them what they'd done so they could arrest them and bring them to Highbank. This was a young woman needing mental health support. So my question is, do you think, with all of the work that has been done so far by PSNI, and we'll get an opportunity to ask Kath what they've done, that police officers are being taken seriously when they bring somebody in and they can clearly see what's happening in front of them? Or the health professionals listening to them?
I suppose, and it's building on what Ryan said in his opening remarks, it is a challenge for what we see in front of us and then what that person presents like when they go into the health setting. And very often we're making decisions based on our immediate need for care and control under if we do detain them under 130, and that can often change when we get to a health setting. So we're as the ACC was saying, we're not in a position to make those clinical judgments, and sometimes when we get to the A&E or ED department, we could be waiting for, as we said, on average 12, 13, 14 hours, and the situation for that individual can de-escalate and change. And that presents us with, I think, a challenge in terms of what we see and that waiting time. But certainly we have issued for our frontline officers interim mental health 130 guidance, which we'd be happy to share, but that just reinforces their role in dealing with an individual who is in mental health crisis and what we can do and what we can't do. But again, I would just stress, when we get to the ED setting, things can change, and it's very different for the assessment from our perspective versus that of a clinician, which can be some hours later.
Thank you.
Thank you, Linda. I'm conscious that Stephen Dunn has to leave shortly, so I'm going to bring in Stephen now with his question, which relates to lessons learned from the rest of the UK around right person, right care.
Thank you, Chair, and thanks, folks, for the presentation. Just in terms of, you mentioned at the start of your presentation, 43 police forces in.
Oh, we've lost him.
We've lost everyone.
He's back.
I was just muted there. Sorry about that. Yeah, you mentioned at the start of your presentation 43 police forces in England and Wales that have adopted this or a similar scheme. What about Scotland? Have they done this? And if not, why not?
Yeah, thanks. I'm going to bring the team in. Scotland have arguably probably gone further, actually, in terms of how they have approached dealing with kind of mental health demand collectively across the system. But I'm going to bring the team in because I know we've discussed this very recently, haven't we?
Yeah, so Police Scotland, as I understand it, haven't gone under the right care, right person banner as per England and Wales, but are doing something in effect the same concept, engaging with health within Scotland to reduce mental health demand on policing and ensuring that people get the right support. It might not have the right care, right person banner, but they are doing something similar.
Okay, thank you. And certainly, like everybody around the table, appreciate the challenges you're under, and we've all seen it for ourselves, certainly in the EDs and so on. But I suppose just the final question is, ultimately, is there a risk of vulnerable people? We know the mental health has increased. You talked about that at the start, and unfortunately, that trend will probably continue. That vulnerable people with mental health issues could fall between two stools, where you have each agency perhaps denying responsibility or saying it's the other sector's responsibility, and I think that for me is one of the key challenges, particularly given the pressures on both yourselves and, within the health service. That would be, certainly a red flag to me, and I suppose it's how you're going to manage that.
Yeah, I mean, I think my starting point, Stephen, is that things are not right now. So you can see from the Caudry case and many others that with policing, with police officers kind of filling a gap, it's not right. They're not the right trained people to do it. It's not a trauma-informed way to deal with people in mental health crisis, and actually it kind of an exacerbating effect. A police officer turning up in uniform to someone in crisis, it's not a therapeutic way to deal with it. I suppose my starting place is it ain't right now, but this work, I want to try and help to address that, but in a way that doesn't increase risk, because I hope I've made it really clear. I don't want vulnerable people to be left without support, and I wouldn't countenance or sanction work that would do that. In fact, we're police officers. Like, I'm a public servant through and through. My mum was a mental health nurse, my dad a teacher. I kind of want to do the best for people, and I want to make sure that this does the best for people. Just the status quo as it is at the moment isn't doing the best for people, either those in crisis or for the community, because so much of police time is being spent on this and not doing what police officers should be doing, which is protecting people from harm. But the governance that we have in place and the data is going to allow us to work in a systematic and thoughtful way to understand where those points of risk might be, and to put in place the decision-making models and the pathways to help support people in those. As I said, from the data, actually at the critical high end, we're still going to be going if somebody's posing immediate risk of serious harm to themselves or to others. It's much of that other work where at times we're maybe just filling in for time for other agencies that haven't been able to make it, or we're sat in the emergency department because the out of our social work isn't able to make it there in a particular time. So those are the kind of lower risk but high volume issues that I would like to probably start us working on first. So I hope that helps a little, or reassure you around that.
Yeah, no, thanks for that. It's just supposed to re-echo and re-emphasise the demand for, the emergency mental health responses simply won't be disappearing anytime soon, unfortunately. And I suppose just finally to say, and I've seen it myself within EDs, the presence of police is, with extremely vulnerable people, it can also reassure other people who are sitting in very close proximity when they see police there, that they do feel safe as well, given, it could be in the middle of the night during the early hours. I've seen that where, you can have a patient with, special circumstances, and the presence of police does have a positive influence too, perhaps, on others, people's safety in the area as well.
Yeah, and then that's one of the things we'll hear from health colleagues. They feel comfortable having the police around because they don't have the security they feel they need within EDs. The trusts don't have enough money to put security on, or CCTV, or various things. But I guess I suppose the corollary of that is that when we're sat there, we're not going to the burglaries, we're not protecting women and girls as they're out in their nighttime economy at night. And that, I guess, is a balance that we all need to strike collectively as kind of citizens with a stake, is what do we want our police service doing? Is it focused on policing, or is it focused on other elements which we're not really trained to do because we're not healthcare professionals?
Yeah, thank you. Thanks, Chair.
Thank you, Stephen. All the best. Neil, I'm going to come to you now. You've got questions around social services, young people in care homes.
Yes, and I will keep my questions short because like Linda, I do get to ask at the policing board quite often. And the Health Committee Chair stated the 5,000 call-outs to children's home, and I recognise only 2.6%, but actually a lot of the young people who are in Woodlands have come from care experience background, so it is very important. And I just want to ask, with regards to right care, right person, and the independent review of children's social services, what engagement with the PSNI, because I know that the PSNI want to engage, what engagement you have had with the Department of Health regarding the issues particularly relating to that. And you mentioned the legislation that you're examining, so with regards to right care and where it fits in. So in the context of your duties, has there been examination of the Children's Services Cooperation Act to make sure that all obligations are met under that?
I'll come in initially just in terms of the So in terms of the approach to young people and right care, right person, we're kind of absolutely kid gloves around that, because there are, I used to be a detective superintendent in the public protection world. Gary worked there as well. There are really tried and tested safeguarding mechanisms around young people and partnerships around that. I work regularly with Helen McKenzie at the Safeguarding Board. I just met last week with Chris, the Children's Commissioner, just to talk about right care, right person. We really want to see right care, right person add value to that rather than complicate what is already, I think, a really pretty robust set of processes to help look after young people. I'm very conscious, I said it earlier, I think we all are, about we want to reduce the amount of time that police are spending in care settings or with young people who are looked after, not from the sense of reducing demand on policing, but more from the sense of the risk that it puts a young person into the criminal justice system when they don't need to be, simply because they're in a heightened state of emotion. The work around then the Philomena Protocol and reducing some of that, I think, has been really positive in relation to it. So we're at really early stages about it. It's probably the bit that we'll get to later rather than sooner. But when we talked about opportunities earlier, I just think young people deserve the right care from the right person. So if we can add something from the work that's happening, we might learn in relation to that, then we'll try and grapple with that and see where it adds value. But I'm very cautious about it because I don't want to see any additional harm to young people. If anything, we just want to be supporting, making sure they're getting the right care. And maybe want to talk about the kind of looking at the legislation through CODRI. Again, it's very early stages around that.
It is, yes. But actually, just to go back to the independent review of social work, we are actually meeting them tomorrow, the independent reviewers, to have a conversation, the ACC&I. So to look.
First time?
I think it's the organisation may, but certainly we are meeting them tomorrow in relation to particularly the right care, right person. In terms of right care, right person and the policy for young people, nationally there's a huge amount of work that has been done, and there's as Ryan was saying, we did meet with the Children's Commissioner earlier this week or last. So we have walked through what the national policy looks like, and we are now working through what that will look like in Northern Ireland in relation to our own local legislation. So we'll work through organisationally ourselves, but also map that across with our health partners.
It hasn't been completed entirely, but will be.
It's definite, particularly the young people is a definite strand of right care, right person. It is nationally, and we will adopt that here.
And I think that's helpful, and we'll ask the Department of Health, I think, more questions on that. And some of the people here might not be aware, but I wonder if you could speak a little bit about, briefly, Operation Encompass, because the good work that the police have been doing on that. However, you have no control over how social services, if they can or are, picking it up on the other side.
Yeah, no, and I don't want to overspeak because my colleague ACC Davy Beck, who is the lead around public protection issues now and young people safeguarding and Encompass, could speak much more eloquently than I around it, although it was something that started both, I think, back in Gary and my day in public protection. So in essence, it's a great model whereby, because police will be seeing young people at 3-4 in the morning in houses where there's sadly domestic abuse taking place, and then previously, when that young person was going to school in the morning and they may not have had their packed lunch or their blazer or whatever with them, the school wouldn't know about it, which felt a huge gap. My own wife's a school teacher. I know she is hugely supportive of the fact they're able to get that kind of information to allow their pastoral support. It took a long time to get there, to get the kind of, the IT and the mechanisms in place to be able to allow it to happen quickly. And then it gives the schools that information as well as colleagues within social care. But it feels very positive. We're very supportive of it because we think it's a great way of getting information to people who need it. But I don't want to speak too broadly in terms of other kind of concerns or issues around it. But it's just been very positive. It was something that I think was picked up and run with, and we've rolled out across Northern Ireland in a really positive way. Okay.
Thank you. Can I just check with members, is everybody familiar with the Philomena Protocol? I'm conscious throughout all of this that there will be those of us who are a bit more au fait with PSNI and DOJ jargon and acronyms, and vice versa for the Department of Health. So perhaps it would be helpful if all officials who are in the room at present could be mindful of that for the other side of the room. Perhaps, Ryan, just very briefly, if you would give us a quick summary of Philomena.
Yes,
please.
and very simply, in the simplest terms, in essence, when a young people is perhaps absent or goes absent from a looked after setting, it's a process whereby the guardians, the home, will do a certain number of checks and ways of trying to see if they can locate the young people, the young persons, before then calling the police, so you're not effectively going to the police immediately and essentially risking criminalising the young person because you've got the police dealing straight out. It's been something that's done incredibly collaboratively, led by our colleagues in Public Protection Branch from the policing side, along with health and social care partners. It feels like it is now well embedded and has been done in a way that's been done thoughtfully and hasn't increased risk or harm, and there's regular reviews of it. So it feels like a real success story. Certainly from the police perspective, we feel that's worked really well.
I'm going to come to Deirdre Hargan, who's got some questions around the current status of right care, right person, and the protocols and boundaries around it. Deirdre?
Yeah, no, thanks very much for your presentation, and I think it is good you're using the initiative to try and do more collaborative, joined up work, and it's good that we now as committees are starting to do this more, and I think the more we do that, the better. I just wanted to ask then in terms of the status, because you'd said just in your presentation that there's an oversight group now between the departments and yourself that's been established. Obviously, the right care, right person approach is an operational model which the PSNI are obviously pursuing for the reasons and the stats that you've highlighted. But it's to understand the current status then, where the policy sits for this project. So is it with the police? Is it in the oversight group? And I suppose just issues around, because I know it touches on in the presentations around Article 2 and 3 rights and how they're engaged or not. And has the programme itself been a quality screen, for example, in terms of looking at those vulnerabilities? And my other question is around, obviously you touched on Humberside and Bedfordshire. I know there's been reviews and you can see the reduction in police call-outs and stuff. But has there been any other learning in terms of, I suppose, the implementation and how that's working operationally? Are there Article 2 and 3 issues that are being engaged with, that there's learning that could be from those examples? And I suppose when the Chief Constable was in front of the Justice Committee a few months ago, he had talked about as well in terms of the link up with An Garda Síochána. So again, is there any learning north and south as well as obviously east and west that we can garner, that you have had through some of those engagements so far?
Yeah, okay, happy to take all of those. So first of all, nothing has been done with right care, right person yet, other than the preparatory work that I've talked about. So much of the work that I and the team have done have been having those conversations with health partners to kind of get the momentum to get agreement about trying to take this work forward. So we haven't done anything unilaterally in relation to it, because that wouldn't be the right thing to do. And of course we are operationally independent, and you could take the approach of saying our thresholds have changed, we're no longer going, but for all of the reasons we've discussed, I don't think that's the right way to do it. And in fact, probably that is the learning, one of the chief learnings from the developments in England and Wales. So there's probably two key bits to that. When I spoke to the project lead many months ago about how we might start going about this work, the first was you need to get some data, because the kind of questions you'll get from colleagues in health will be, what will that mean for us? And I reflected that in my opening remark, because they also said that actually from a health perspective you will find, and the conversations you have reflected this understandably, that from a health perspective they actually have no really good way of understanding how many times they pick up the phone to the police, and how much demand is coming the police's way, because there's no way of capturing that. so that they had said get some data, because that actually starts to make the conversations more meaningful, because it deals with that issue of what will it mean for us. You're actually saying, we'll have a look at this is what it could mean, and how can we work together to deal with any challenges that arise from that. So that was number one. And number two was to do it in collaboration and partnership to get the maximum benefit from it. So yes, of course, as I said, there are bits we could just say we're going to do, but that would not achieve the maximum benefit from this, which is about getting the right care from the right person. There is, of course, all of those entirely ethical secondary benefits of police being able to do policing, of course. But the primary one is about, at the moment, people aren't getting the right care from the right people. So I need to do that. That needs to be done collaboratively and together, and that's why I'm really pleased. It feels like it's taken time because I'm impatient. I want to see change, and I don't think it's right as it is now, but we've got to a position where we now have the governance that will allow us to take that forward collaboratively together to explore these issues and put forward a kind of pathway about what aspects of it would go live at what time. So it's a long way of saying we haven't done anything yet, because I guess in the spirit of collaboration it wouldn't be right to do that, and we want to do this together.
Just sorry to follow. So the governance and oversight, that's DOJ, DOH and yourselves then?
Yeah. Well, it's chaired, and you'll hear from colleagues, I think, from the departments afterwards. So it's chaired by Department of Health and Department of Justice, which is really good, because I've been quite conscious. You know, we've been pushing this. We're doing a lot of the driving, and so that can sometimes come across as this is about the police trying to reduce demand on themselves. And I'm sure people can get a bit, they get a bit fed up of hearing that. They kind of, it feels like we're doing all the pushing, and actually we need to do this together. I kind of need health colleagues to push into it, to take ownership and to drive some of the change. And that's what the governance will do, taking the emphasis away on me having to do all the work around it and actually trying to do it together.
Sorry, just my last bit on that. Is there a terms of reference then for the oversight group that's been established? Can that be shared?
Yeah, absolutely. And as I say, I think Mark and Peter are coming in after, so you get a chance to explore that with them as well. But absolutely. And
then, sorry, it's that group then will start to look at the screening, Article 2 and 3 rights, all of those issues then that would come through.
Yeah, I mean, how we see that group working is, so we have that kind of oversight, if you like, and our policing terms, the gold group in effect, is kind of bringing together all the kind of strategic leaders, and we've had the Royal Colleges there are going to be there as well. There's a representative from one of the trusts in terms of giving a kind of user perspective. So there's a range of those around the table, and then the kind of operational working group that Gary and Una were very much involved. I think Gary's going to jointly chair that with a colleague from Health. That will start to do the doing and do exactly everything that you were saying in terms of plotting out what it could look like, and then thinking about all of the kind of contingencies and screening, etc. in relation to that. So that's all work in the future, some of which I'd like to see progress on quite quickly. Others I know it's going to be more long term.
The co-design.
Co-designed, absolutely.
Thank you.
Justin, you wanted in on this subject?
Thanks, Chair. Challenges that may, thank you all for your evidence. Challenges that may arise from Article 2 of the European Convention on Human Rights may be engaged when the police are aware or should be aware of a real and immediate risk of life, including from self-harm. Interpreting this in relation to right care, right person could be challenging in relation to developing guidance and for officers dealing with particular circumstances and incidents. What's your perspective and what's your take on that?
Okay, no, absolutely. We're really acutely aware of that. I mean, you hopefully will have picked up from the information, the data I gave at the start, that kind of acute risk to life is really in the margins in terms of how much this work is. The majority of it is much more an everyday unmet health demand where there isn't that risk. So I think that's good in terms of how burning bright that risk is. The second bit being is we're coming to this much later than others. So a lot of that hard thinking and policy development around what decision-making trees will look like, what referral pathways would look like, are again now becoming tried and tested. So that information will be sort of absolute gold dust for us as we're all developing this as we move forward in relation to it. So that's where I see, I take confidence from the fact that is being worked through. It's actually operationally happening now, and we can see that it's been done in a safe and a way that's bringing some benefit. So I take comfort from that.
Again, how will the roles and responsibilities of specific agencies be established to ensure no individual falls through the cracks, and also to avoid silo working? And how can this be manifested with current funding arrangements?
Can I just stop you a wee second? What we're kind of working through at the minute is we've got a list of kind of themed areas, and we're kind of sticking to those. And then, which means that other people can jump in on subject areas, rather than if we do it by member, we'll be here for eternity. So with regard to that specific issue with people falling through the cracks, can we come back to you on that one? Would that be all right?
Fair enough.
Thank you very much. I appreciate that. It's just to try and help us flow a bit more smoothly, if that's all right. Orly, I see that you have your hand up. Is that again with regard to a specific question in this area, or just another general?
Yes, Joanne, it was just to follow up on sort of how you can try and roll out this sort of policy and partnership approach. I wanted to ask a wee question on that.
Yes, go ahead.
That's okay, thank you. So it was just obviously conscious that there is other successful pilots and projects that have been rolled out in the past, and I know the chair had mentioned earlier around the MAT pilot project, which has been successful, and I know more recently then there's a pilot project being rolled out in the South Eastern Health and Social Care Trust, the Hear and Treat mental health service, which is again another form of a sort of telephone triage line. And then I know that the Department of Health, Mike Nesbitt, has said that he is also looking at, if you know the model, the 111 model that's being rolled out over in England, where it's specific for people particularly with mental health needs. The department have also says that they are considering rolling out a similar regional health and social care 111 telephone line that would have a mental health specific sort of hub or section. So I just wanted to ask, because obviously that's all really good partnership working that's being explored and being taken forward between health and social care, and obviously PSNI had involvement with the MAT. So has the police been speaking with specifically with the department in terms of that Hear and Treat phone line service on exploring the 111 regional service? And then just finally, in conversations with the team that's dealing with the regional crisis service, because obviously I think all of that is really important to be interlinked to the work that you guys are trying to do with the right care, right person.
Yeah, thanks very much. A really kind of valid question. Just to reassure you around it, so we have really from the start of this been acutely aware around the development of the regional mental health strategy and all the constituent parts of that as it develops. So Heather, who's kind of leading in the development of that within the Department of Health, sits on and works incredibly closely with Una around the development of this work in right care, right person. So we're really trying to spot the interdependencies. We're trying to kind of get out of the way to let things happen that we think are promising and are going forward, and we're kind of getting in the way where we think we can probably add some value into it. Where you see this, I guess, for me, where we see a real gap. So I used to be the district commander up in Eric met up in Derry, and every day you would have somebody presenting at the Foyle Bridge. Not necessarily intending to take their own lives, but as effectively a way to say, can someone come and get me some help? And inevitably that will be the police. So the police officers will go, they'll make that very difficult decision around whether we're going to detain or not, but more often than not they will bring them to Alton Galvin Hospital, and then that process starts of waiting for assessment. And it is not untypical that that's sat waiting for 24, 48 hours, and then I think as one of the colleagues in the committee said that because of that time, often as how the person is initially presenting and drinking drugs maybe start to wear off as well, because often you have these factors going together, and you'll understand better than most that the person then is released, and then where do they go again? They're back onto the bridge because they haven't got the kind of help and wraparound support that they need. So where you can see crisis mental health support in the likes of Humberside develop is that it's very operationally proactive. So when the officers are at that bridge, they have got a phone call they can make to the regional service to pass them to the person, and then the police can in effect disengage in that voice, and you have the wraparound care, the kind of pit crew I would talk about in terms of being able to support somebody in that need. And that is a gap, I think, an absolute gap for us here. So we want to support all that work, and I mean, part of the reason for me being here is to help to amplify the kind of need collectively on behalf of those in justice and in health, to say that this is something that we need collectively resolve. So I hope that helps. And I don't know if you want to say more in terms of just how well connected you are in there. We are.
Just to add, certainly it's our intention. I mean, we're involved in the regional crisis care service planning, involved in the regional mental health strategy. We sit on all of the, well, as many of the working groups on work streams, and I know that Matt is one of the work streams, and they're looking at how that can be extrapolated out regionally. Matt is successful. We are looking at a review just in line with all of the work that we're doing around Caudry, making sure that we're not duplicating or triplicating, and how our own services and what we're doing with health and other partners and the community and voluntary sector as well actually interlink. And I think it's important just to mention the community and voluntary sector. They will be involved with right care, right person as well. There's in terms of our silver group that will work with the oversight group. So I recognise there's a lot of pilots. There's been a lot of work ongoing, but we're at a stage, I think, where we, in this relationship now with the Department of Health, that we'll now be looking at the interdependencies more closely, particularly with Matt, with right care, right person, Caudry, and particularly the regional crisis care service.
No, that's brilliant. Thanks very much. And I'll finish on this, Joanne. But it was brilliant to hear even about the training that you have rolled out with the officers, the mental health first aid. And I'm sure you will be taking this into account. But in terms of training and what comes out of right care, right person, and all the work that you are doing with the Department of Health, it's just to remember to try and keep addictions almost on par with mental health. You know this yourselves anyway, but it's as important if an officer is trained in terms of mental health, that they also have a good sense and a good grasp of what it takes and what it entails when you're dealing with addictions. But look, I'm sure you are fully aware of that. Anyway, it was just to make that wee point. Thank you.
I think just to add there around the mental health first aid training, we do have community and voluntary sector input, and addictions is one of the presentations within that. So there's a definite awareness and link into the link between mental health issues and addictions.
And one of the kind of bits of work that we've been able to do over the past number of years, which probably I feel really personally incredibly pleased to be able to take forward, is that we brought nurses into our custody suites. And that means where before, when somebody was in custody with a whole range of vulnerabilities and issues and addictions and mental health, that they were in for criminal justice purposes, and we weren't doing anything with them in terms of being able to signpost and be able to look at some of those other connected issues. Having nurses in the custody suites means people are getting tested for Hep B and other illnesses, routinely screened. They're getting direct referrals through to drug treatment and mental health treatment when they are with us in that. And I think that's a kind of a really great step forward in terms of understanding that there is complexity within there, and a public health approach to it. Health approach is a really key part of it. So I think I'm really pleased with how that work's taken off.
Thank you, Rand. Justin, in fairness to you, earliest question moved slightly beyond kind of protocols and into partnership working, which will tie in with your question around people falling through the cracks. So I'm going to come to you now, if that works for you.
Okay. How will the roles and responsibilities of specific agencies be established to ensure no individuals fall through the cracks, and also to avoid silo working, and how can this all be manifested within current funding arrangements of respective departments? And will this have a direct impact on the visibility, accessibility of officers on the ground and in the community? I'm not sure if I misheard you earlier, Ryan, when you mentioned only 50% of the officers you need are on the beat. I'm not sure if I misheard you, but where does it all sit in relation to your Chief Constable reaching out to the Prime Minister of the UK seeking additional funding, with Permanent Secretary in the Department of Justice admonishing your Police Constable for doing the same? give me your perspective on that, please.
Yeah, thanks. Probably a number of points there to touch on. So hopefully in what you've heard in terms of how we haven't started anything on this yet on our own, and that we are committed to doing it collaboratively with health colleagues, will be the way we spot the interdependencies so that people don't fall through the cracks. Again, I'll say people are falling through the cracks now. If we were to pretend the current way of approaching this is right, it is not. And Caudry and other incidents show pretty clearly that things need to change. But it needs to be done in a thoughtful way that has people at the heart of it who are vulnerable. So we will work through that, and we've got the data to help us with that. What we have been able to do by virtue of, I guess, some of that time that has taken to get us to the point of getting the kind of joint commitment to move forward is to start to explore what the kind of decision-making models and pathways look like within contact centres, because much of this for the policing starts at when the phone is picked up in the first instance from the ambulance or from another part of health to us, to help that decision-making process and also the escalation processes. So it's not simply a question of us saying, actually, we don't think this is right for us to go to, but there's a process to escalate that if there is a query or actually our partners feed, you know, that's not right, you really should be going. And actually for our contact staff, we're developing a really comprehensive programme of training for them. There'll be no performance targets around this. We're not saying to people, we want to see X amount of demand taken out of policing. What a terrible position to put someone in making a decision about someone who's vulnerable. We just want to give them what we haven't given them now, the policy and top cover to make decisions, because at the moment they're doing it blind, and we want to give them some policy and structure to help them to do that. And we can see from what's been done nationally, in England and Wales, that has taken shape in a way that's now becoming tried and tested. So that all certainly gives me some reassurance that it will be able to spot people who may potentially fall through the cracks. But the funding is you mentioned the funding I talked about in my opening remarks. Policing smaller than it ever has been since the PSNI came into existence. We have half the neighbourhood policing teams that we had 3 years ago. That draft is being felt in communities because when the police aren't there, who fills that gap? And
we're going to come on to financing, because Diane Dodds has a question around those subjects, and I appreciate that Ciara has some questions around what you've spoken about with regard to the community and voluntary sector. But just in terms of your decision-making pathways and making sure that everybody's abundantly clear, there were references in our papers to, I suppose, an example from the UK whereby a coroner, a woman had passed away, and a coroner kind of indicated that if partner agency working is to be effective in caring for this extremely vulnerable cohort of patients, there needs to be crystal clear understanding by all those involved, from the highest policymaker to the most junior member of the team at the sharp end, of how to tackle these difficult situations and exactly who is meant to be doing what. So is it your intention, and I'll pose a similar question to health officials and justice officials too, to ensure that everybody would be very clear who is doing what, and when people are referred on, so that you're going to minimise through decision making and availability of services? Because the thing that strikes me about all this is whether or not, and that was one of the questions that I had for you, whenever you attend a call that really is not for the police and the person needs medical attention of some description, whether that's mental health crisis and so on, are the facilities and services available if they're to be redirected? What is available outside of working hours and at weekends? You know, because it's all right redirecting people, but if they're not going to be attended to, then we're just kicking the can down the road, and we are not providing those people with the best services available. So that's a question that I'll come to with DOH also. But I'm keen to know your experience in that regard, and what then, in terms of the partnership working, what you intend to do to make sure everybody is very clear on what the responsibilities are and where they end.
Yeah, thanks. And again, this is where the structures that are in place will be used to work those things through in a very kind of practical and operational way. it is a, you know, it's a challenging world, isn't it? Not everything is black and white, and as best as we can through this work, we want to deliver the kind of training and joint working that that allows us to all have a bit of flex to be able to deal with whatever is presented to us. So the EDs are a good example. What I would like to see there is a very clear process for handover, so who talks to who and says what. That's not in place at the moment, and that doesn't cost a lot of money to make it happen. You know, I know we're going to talk about money, but actually some of this is very operational, very about custom practice, and some of it's around culture as well, because money actually could be something that inhibits progress because we focus on that, and actually we don't concentrate on the things that is absolutely in our gift collectively.
You could save money upstream potentially.
To do something about.
We'll come to the money aspect, so I'm keen to kind of...
So those processes about who will do what and when will be very much part of the process as we develop this, as we move forward. So, and we'll work that through. I'm going to say we'll learn from what we have seen is in place elsewhere as a kind of teaching aid for us all, but it needs to be right for Northern Ireland. That's the thing as well. So I don't want to give the impression this is just a lift and lay without any thought going into it. It has to be right for Northern Ireland. It has to be sensitive to the health and social care settings that we have. Some of the way in which we work is different. So of course it has to, and that's why we're doing that together to help understand that.
Perfect, thank you, Ran. Ciara, while we're on partnership working, the community and voluntary sector was mentioned. I know you have a question on that area.
I suppose essentially of obviously core day, when you read all our presentations here today, core is that collaboration, but first of all it's putting the people first, not the data, not the stats, not the agencies. It's the people first, it's then the family, it's then the community, and then it's the interagency collaborative work. So on that, and in relation to your data, which he says was key, and the 41,000 calls, which is quite stark, and it's good to know. But behind that, how many individuals actually is, because from my experience and working with yourselves in Derry, in the Outer North area for 20 plus years, the community, the families, the schools, the police know the individuals in the communities, and it's a small number, but it's a daily phone call, if not 3 or 4 phone calls a day for that individual who is out in the community quite vulnerable. So I'd be really interested around the numbers. You may not be able to provide them today, but I'd be really interested to find that out. Likewise around the mental health. But you mentioned the word gold dust. To me, gold dust is the community. And from your presentation, I seen the word NICFA mentioned once when it came to the operational side of it. And I think you have done a lot of good work to date in raising it across the Department of Health. But I'd like to know what engagement you've had with the likes of the Housing Executive, our housing associations, our floating support teams, our community safety partnerships on the ground, our family support hubs, our schools, our mental health charity organisations, our neighbourhood policing teams, our floating support teams who are on the ground every day, who know who the individual are, who know who on the ground as a collective what support is needed. That could really be the gold dust for any model moving forward. So really keen to know where is that at in relation to progressing this model.
Right. Do you want to talk about sort of NICFA specifically? I know you've had some meetings, etc.
Yes, I mean we're very conscious that the community and voluntary sector and communities have a huge part to play in this. As Ryan did mention, we are at the beginning of establishing the governance. The oversight group met last week for the first time, and Gary and I are putting together what we would refer to as the multi-agency silver. And when we say multi-agency, we mean multi-agency. So, you know, taking that forward, it will have a range. It's not just going to be health and justice. It will be community and voluntary. We will look at other departments and other agencies and invite them in. It's just making sure we have the right people around the table, and some of your suggestions are really welcome. I appreciate that. So I'll take a note.
Drill down to your neighbourhood level. Because if you don't hit the neighbourhood level, you can have the strategic, you can have that high level operational.
Totally agree.
But if you don't hit the neighbourhood level,
I think
you're missing the gold dust that could really have the biggest impact in supporting our most vulnerable.
I mean, certainly one of the plans or one of the strands will be the rollout of e-learning right across our organisation, which will explain what Right Care Right Person is and will, you know, that will come from the silver multi-agency group, so that it will be the learning of what this is, who to speak to, what, you know, the engagement on the ground. So all of that will be brought together into that e-learning package. It's not just going to be, this is right care, right person. It's going to be, this is what, as an officer or as a staff member, you will be doing, or you can do, in partnership with agencies and communities on the ground. This is about on the ground delivery. It isn't just, it won't just be the strategic strands.
And we want to try and sort of eat the elephant in manageable chunks around this work, if you like. So I talked at the start around there's kind of 4, I suppose, key areas to it. One of those is around the emergency departments and waiting times, and there are models out there where the third sector, the voluntary sector, have an incredible, where they're able to almost perform the handover role in effect. So you'll have somebody there that actually is able to wait with someone whilst they might be waiting for their assessment, for example. So you can see some real practical ways in which some of around the key areas of the key interface with the right care, right person, where the voluntary sector can be hugely practically involved. I mean, we work every day with the likes of Lifeline and others in terms of trying to deal with some of the kind of mental health demand. So again, I think a really important part of it is the kind of voluntary third sector involvement within it. And again, I suppose I go back to we're a relatively small team. It's kind of the 3 of us, and we're regularly going to meetings with health colleagues. There's maybe 30. So we're kind of doing our best to raise as much awareness as we can, with the hope that the governance arrangement will really start to bring some of that, as you were saying, bring some of that together. Because again, I am at the point where I'm pushing so hard. I want to be more of a help than a hindrance around. I think now is the time for others to push and start to bring some of that together, because otherwise it'll just feel like a police thing, and I don't really want it to be a police thing. But absolutely, the third and voluntary sector, I think, have got an incredible asset around helping to support some of this, and it's hard to do when you get very piecemeal funding arrangements, because you can't then sustain the support.
Ryan, you need to keep your answers succinct,
Sorry.
because the more you chat, the more other people are
More
thinking of
questions.
questions, right? Do you want to say on this point?
Just on the numbers,
right?
You've given the calls,
Yes.
but the number of people behind those calls.
Yeah, I'm not sure. We'll have a look at that. I'm just not
just
sure how easy it is, but we'll have a look, because often you get a call, but it might be from, say, the ED it might be the Mater Hospital, and it'll be recorded as the Mater, not Ryan Henderson, or if a family member rings. So we probably the detail of individuals is probably contained within the incident and isn't searchable quite as easily as who made the call in the first instance. But we'll see what we can do with that.
Would you agree that it is a smaller number of individuals who is making? I know ones that I worked with in the community, and we were ringing them every day through a family support hub. The credit union was ringing them every day. We were taking them to the GP. They were ringing you every day, and you were calling out and lifting these individuals. And that's
definitely a part of it. But I wouldn't want to say that is it all, because much of the data that I've talked about are things that are, I think, very routine. Somebody hasn't turned up for an appointment on a ward, and the police have been the first person that's called, or the ambulance can't get somewhere, but they've categorised it as a particular category, and they might get there in 4 or 5 hours. When they call us to say, we can't get for a bit, would you guys mind going? So those aren't necessarily about that. And it would be wrong also to say that this is simply about mental health vulnerability. There's a lot of this demand is people who are just unwell in terms of purely health, physical health issues, not simply mental health. So mental health is a part of this work, a significant part of this work, but a lot of it's probably more just general health. Sorry, Gary, do you want to come in there?
No, it's fine.
It's 50% according to your figures, mental health, so it's hugely significant.
You wanted in on this
This was
point?
just really to emphasise the issue you touched on in terms of the community and voluntary sector, and obviously the larger voluntary, such as the one you mentioned, play a vital role. But it's notwithstanding that grassroots connection, particularly on the operational end. Yeah. And there needs to be a way that they're part of the co-design process of this. I just know there's one pilot in Belfast, Complex Lives, and that's the one gap that communities are raising concerns about. That there are voluntaries in, but there's no connection at a neighbourhood level up. Yeah. And often that's where the care breaks down and these vulnerabilities present. So as a way of trying to get upstream in prevention. So I would just implore that as you're going through the co-design, that you're taking into account that very grassroots neighbourhood participation and involvement in it. Thanks.
Okay. Diane, is your issue on this point or something separate?
Sorry. So it's a really interesting conversation, and I apologise that I wasn't there for the first part of it. I had a meeting which massively overran.
This one is likely to. Just, Diane, can I just check with you though, is the question you have on this point?
Yes, no, about the pathways. So you talk a lot about the pathways that people will have to be engaged with, and that you can direct people to. Are you sure that there are enough pathways, that they exist in all areas of Northern Ireland? And I don't mean urban areas, I mean rural areas, the type of areas that I represent, and that they're open and available at all times. Because, I mean, one of the things that I get quite significantly is that people turn up at Craigavon ED because there's nothing else for them. That's all there is. Or police escort them and sit in Craigavon ED because there's nothing else for them to do. And it just seems to me that if you're going to create a new system, and I think that the idea of collaborative working, and Ryan, nobody's suggesting that what's happening now is appropriate or even right. But it won't be appropriate or right if we don't have significant increase in availability for places for people to go and where they can get help.
Yeah, I mean, I don't disagree, Diane. I think one of the reasons I said I'm here is to help amplify that those challenges that are very real in terms of availability to treatment, access to treatment. There's definitely a kind of rural aspect to that as well in terms of how quickly and easily people can get it. I guess that is the point of the programme of work, is to kind of understand where those difficulties and rubs are, and to try and seek ways of trying to address those, either through new ways of working or perhaps through funding. I just want to kind of stress again, but actually a lot of this, at least a significant proportion of this, is about better operational working, better understanding what the police do and what their role is in terms of other health agencies and how we communicate with one another in terms of that. That I feel is quite achievable, it's quite doable, it doesn't take money and it doesn't increase risk. But all of those other issues you raise are absolutely valid, because I see them and our officers experience it and understand it every day, absolutely.
Okay, Diane, yes. Thank you. Just on the operational working points, Ryan, I know that, and you've mentioned officer hours and attendance at A&E on a number of occasions, so I know that Maurice and Danny have questions in that area. Maurice, do you want to go ahead there?
Yeah, sure, Chair, thanks, and thanks very much for your presentation. It's been very interesting, and your right care, right person project is good in theory, but it's the practicality of outrolling it is going to be the difficulty, putting the meat on the bones. Yeah, I know from experience this past 3-4 weeks of being in A&E quite regularly with elderly people. When people come in who have got mental health issues, but mostly substance abuse issues, there's an unease within a packed A&E. The patients in there, some who are gravely ill, are very uneased. And if there's a way, which I had time I was on the policing board, I had maybe suggested, of isolating people who have got mental health issues and substance abuse issues away from the main A&E waiting area, it would create a bit of security for people who are genuinely ill. And I'm not saying that people who have got mental health or substance abuse are not genuinely ill, don't get me wrong. But there is another terminology for people who are in real need of seeing someone in an A&E setting because they need it or there's no other GP facility available. So have you had any discussions about isolating people who have got police escorts away from the normal A&E setting to give everybody assurance? The number of assaults that has gone up within A&E departments is another grave concern about handing over to volunteers. Are the volunteers insured? Are they safe? You know, that's an issue as well. And when you talk regional, what do you mean by regional? What's regional mean to somebody from Newry, from Enniskillen, from the Causeway Coast? Is regional a Belfast thing, or do you really actually mean regional?
Okay, so I'll talk about was there perhaps somewhere else that people could go? So, and I should have said at the start, I mean, you know, I'm not a healthcare professional, so I do not pretend that I have the skills, training or expertise to be able to say how best to deal with somebody in mental health crisis, and that's why with mental health issues, and that's why we're doing this working together. But I have seen there are different ways, and there has been an active discussion for some time here in Northern Ireland about the creation of suites that somebody who was in need of assessment could be taken there rather than to an emergency department. They have those in parts of England and Wales, what they call 136 suites. And certainly the policing experience is that they are much quicker, people are getting their professional support much more quickly, and it takes it out of the very challenging operational environment of emergency departments. You know, I do know, however, there are some might take a different view from a mental health perspective and say that because people are entitled to universal health care, so if they have, you know, if there are drinking drugs as well, then actually they need to be treated for those things, and that's best done on an ED. That's not a discussion I would even say I have the professional expertise to advance, but what I see is that EDs here and now are not the place for people, in my view, with significant mental health crisis to be placed, because it is not in any way de-escalating, trauma-informed, or helping them become better or calmer. So from my perspective, there is a different way. There have been those conversations. It will be, I think, an active part of the discussions around what the regional mental health strategy will look like, and because I'm not trying to change the world through doing this, because absolutely everything that's happening in terms of adult mental health provision is very much about what the Department of Health and what decisions made in terms of that. This is trying to deal with some interface issues between policing and health to get the best for those people that are kind of we're both dealing with. But I think it's a really valid avenue to explore, and we have been publicly supportive of it. But I just put the caveat that we're talking from a non-professionally trained person's perspective, but you can see the feedback on where they work seems to be good.
Yeah, it gets the right care.
It gets the right care. In terms of the regional aspect of it, Morris, are you thinking in terms, so, I mean, yes, we would see right care, right person as being really applicable across all emergency departments, for example, across all trust areas, and the representation on the governance group, so there's somebody from every trust represented within it, so we see it as across Northern Ireland.
Thank you. With your permission, Chair, a couple of other ones. Another one is ambulance teams. You talked earlier on about ambulance teams taking up the role of the PSNI. Well, from my own experience, people wait between 2, 4, 6 hours for an ambulance, and that again is not a good setting to be in. If you've got an issue that needs dealt with, you need help right away. So to be told that an ambulance coming, and it's coming in 6, 7 hours time, is not a good situation to be in if you need help right away. And the other thing is, you talk about having a nurse in a custody suite. I think that's a fantastic idea. But if you live in Ballycastle right through to Portrush, Portstewart, Coleraine, your nearest custody suite's in Strand Road. So it's a wee bit of a difficult area to get from where you are to the Strand Road to be assessed.
No, well, we tend to take them, so it's people that will have arrested or brought, you know, so it's when someone's arrested, and we have the nurses in Waterside, in Antrim and in Musgrave at the moment. So about 72% of all detainees who come through our doors of our custody suites have access to the nurse-led care, which is really good. We're working closely with the Belfast Trust to see how we can push that into the other custody suites as well. So our ambition is, over the next number of months and beyond, to have that nurse-led care within every custody suite in Northern Ireland.
Again, to take someone from my area to Strand Road takes up police time.
Oh yes, well, it's a different debate in terms of where its custody suites are situated, but from the health perspective, in terms of supporting people in that way, we have that.
Okay, thank you, Chair.
Thanks, Morris. I suspect with regard to your ambulance query, I think that DOH officials are going to have to answer that one for you. But I mean, that is an issue, Ryan, that Morris raised in terms of the travel time to and from, and officer time engaged in that. And I think that, you know, if the police are going to engage, and this is a matter for the board, but if the police are going to engage and work like this with DOH, I think there are elements of their own house that need also to be considered. But that's, again, a matter for the board. Danny?
Thank you, Chair. I would share some of Diane's concerns when we're talking about mental health services here compared to England and Wales. Now, our mental health services are under considerable strain. We have huge waiting lists. A lot of the community and voluntary sector that provide a lot of those services are under financial strain as well. So I would be concerned that we're maybe not quite as equipped with those mental health services to be able to step in, as you said. You know, that's where, you know, the handover would be compared to those areas in England and Wales. I would also agree with you that taking a person in mental health crisis to an A&E is absolutely wrong. It's wrong for the patient. It's wrong for the department. Totally inappropriate place to bring a patient. Our A&Es at the minute are very, very overcrowded. They're very, very busy. They're regularly understaffed as well. So bringing somebody into that environment who's presenting challenging behaviours and can be volatile can present as other problems as well. So one of the questions I would like to ask you, in the areas where the right patient, right care has been brought in England and Wales, has there been an assessment of incidents within A&Es? Have they gone up? Have there been any sort of assessment of assaults on staff or other patients or incidents within the departments?
I'm not sure, in honesty. So that's something we sit on the national sort of working group in relation to it, and so we can certainly try and explore what information there is in relation to that. That national group has kind of got health representation, so it is absolutely a joint enterprise. So any issues in terms of impact upon health professionals, in terms of their own safety, or actually risk to vulnerable people, are kind of front and centre in terms of the assessment of how the process is working. There's actually coming up in the next couple of weeks a kind of joint health and policing online seminar, which is kind of going to be actually explaining some of the benefits from it and how all that's worked to help sort of partners more generally get an understanding of it. So it's very much that has been sort of developed together in that way, and I know issues like that are front and centre in terms of assessing the benefit of it. And I think the Home Office are on the cusp of producing a more kind of fulsome evaluation of right care, right person. So we want to learn all the lessons from that. And I go back. I agree that the access to mental health services is not where it should be, and there are some differences in that. I suppose I keep going back to, and I think it's important to say that with us doing that, we are not going to victims of crime. We're not doing our statutory duty. We're not doing what the police's job is actually to do, which is to prevent and detect crime, because we're doing those other things. So the discussion, I think, is more about where can health actually provide the safe system of work and help people within the health environment in terms of those feelings of security and safety. Because when police are there, they're not doing the police job, which communities need us to do. And I do think it's an important element of this discussion, because some of this is about how do we want to make collectively best work of our scarce public resources, our scarce public services, who's the best to do it and who's not. And I think we would all agree it's just slightly skew with at the moment, and we want to kind of just realign it a bit.
The other quick questions, if the Chair doesn't mind. We've heard quite a lot there from yourselves today. I don't think I heard a timeline for implementation of Phase 1 and Phase 2. Apologies if it was mentioned and I'd missed it.
No, it didn't say it because we don't have one, because in the spirit of being collaborative around this, we want to do it together. So we have been doing a lot of, if you like, preparatory work. So in essence, we have got work done around what the training would look like, what some of the decision making might look like in the contact centres, etc., etc. So through the work of this group, I hope we'll get to a position quite soon to be able to say that, and I don't think it's a big bang for every part of it. It's about saying what bit of it might we go live together on first, and it will be together. But and I'd like to see us moving forward in that in months rather than years, because it's really important. I think that we start to see some change around this, because I think that will build momentum and learning. And I know from some of the most positive conversations I've had over the Royal Colleges because they kind of see it. You know, the Royal College of Emergency and Medicine, I had the pleasure of speaking to probably 70 ED consultants who all said it's wrong, it's not working, it's not right. We're delighted you're raising this because we want to get behind trying to make a difference in terms of the operational practice. So I kind of feel people are ready to actually push forward and do some of it because they see operationally the messiness of it, because they're right in amongst it, and I kind of think we want to be able to maybe take some of that forward relatively quickly, understanding that some of the other elements are going to take longer to do, and that's fine, but no hard and fast timeline set as yet, because we've only had the first of the governance groups meetings very recently.
Could you give us an approximate sort of time frame for phase one?
Well, you know, I would like to see phase one, you know, which, and when I say phase one, and again, you're kind of risking me here, almost going against the absolute collaborative. I'm totally wanting to be collaborative in this, but phase one for me probably would be something like the work around the contact centres. So that's a pretty significant amount of work that is passed to us from, you know, be it the ambulance or from EDs, etc., to do some work in that space around actually when's the right time to call the police and when's not. And that's something I think we could do probably in months rather than in years, and that element of it. Some of the other bits are definitely going to take much longer to do, thinking about maybe alternatives to conveyancing, for example, and what opportunities there might be there. So, you know, we're kind of ready to go, certainly in that first aspect of it, but we want to do it together with people. So I'm really loath to say we're going to do it in 2 months' time, because I don't want to scare everybody. I don't want to make people feel that, you know, they're talking out of the side of their mouths about this. We're not. We're genuine about it. They want to do this together.
One last quick question. Just previously, I know that you'd had in the City Hospital in A&E, you had a police presence at weekends. I think, I'm not sure whether it was a pilot or whether it was a programme that you'd had. Did that provide any sort of, I suppose, cover for the other officers that would have been in?
I'm not sure on that one. I think it was probably quite just a local thing within Belfast. It's certainly not something we've kind of systemised and done more widely. I mean, we'd like to see less police time in the ED rather than more. So we hope this work will be the kind of answer to some of that, rather than having to get a kind of fairly blunt fix around maybe dedicating police officers specifically to the hospital, because some of that's probably stepping into the space that the hospital themselves need to be doing in terms of looking after their own staff and the people within it. So I can't really say much more about that one, thanks. I just don't have the detail on it.
Okay,
thank you.
Okay. Members, I'm acutely conscious of time. We're running massively behind, and we still haven't finished with PSNI, and we have other officials waiting in the box, and it's not the best use of their time. So can I please ask people to be really succinct, and Ryan and the witnesses, if you guys would try and be as succinct as possible too. Stuart, you wanted in briefly on this, and then I'm moving to the next question.
Just very, very briefly. What are the barriers to data sharing between all of the official bodies that are collaborating around all of this, and what are you doing to tackle them?
Yeah, and actually on this, there's probably very few barriers to data sharing. So we've, as I now said, got that fairly comprehensive suite of demand, if you like. So we kind of know what it looks like, and we're going to be sharing that with health colleagues, so we can kind of work through that together. So on this particular element, so we're not really sharing personal data about individuals. This is more kind of system level data about, do you understand the flow of calls, the flow of demand, etc., to kind of get into that, to look at it systematically rather than around individual bits. So it's not, it doesn't feel like it's a barrier to this work at present.
Well, thank you, Chair.
Thank you, Ryan. Alan.
Fascinating discussion and presentation and debate today. Within those figures, there's obviously real life per outcomes, real life consequences. And I'm interested to know that within those very stark figures that you presented today, of the numbers of calls that are being directed in a particular way where they should not be directed in a particular way, do you collate similar figures then where there have been those real life consequences, where potentially there has been a fatality or a death in the eventuality whereby you should not be there, and in fact members of the health service should be there? And I suppose on the flip of that, thereafter, have there been incidents? I'm sure there has been, and do you collate those too? I'm not looking for those figures, obviously, but is there cases whereby you have been tasked to these cases that you should not be at, and on the back of that, There have been fatal car crashes. There have been sexual assaults, as we have seen in the Northwest recently, where your officers should have been there and couldn't be there. And I think others who talked about gaps here today, they're absolutely right. I mean, I can give some incidences whereby social services or mental health workers are ringing the police at 10 to 5 to say that they have an individual who is troubled, who's aggressive. They're putting down the phone, they're clogging off at 5 o'clock, and you folks are left to pick up the tab. So those gaps, that's one particular gap that really does need filled.
Yeah, thanks. There's a range of things. I'll try and be brief. I mean, I guess one of the... So if you were to go and talk to go into a station and talk to frontline officers, they'd just tell you how much of this work there is, and they'd also tell you how, to an extent, fearful they are about it, because they will find that they are making decisions they feel they're probably not equipped to do, and they're also very concerned that when they do, and if they get it wrong, then they will end up being investigated by the police ombudsman in relation to it. And that sometimes drives some of their decision making around it. There are cases, absolutely cases, some are in the public domain, where the police, the ambulance haven't been able to go to a job, not be able to make it. They've asked the police, and because we've not had the processes in place, we've said yes, we'll go, and the poor person, because they're unwell, has passed away. And that then means, you know, if the paramedic had been, there would have been a process for dealing with that probably fairly simply, but because it's a death after police contact, then the police officers are referred through to the police ombudsman's office, and an investigation takes place for something really that they have really very little expertise, or I think you would argue really they should have been at that. So there absolutely are examples of those things in and amongst the data, but it's in, you know, it's in the smaller numbers, but it's definitely a very real, has a bearing on how police officers, I guess, kind of feel about this work to an extent, and why I would get it, we would get it, is probably one of the chief concerns for frontline officers, is about the amount of this work that they're being asked to do, and that's probably one of the reasons for it. And also because they don't feel they're doing a disservice to the person who's vulnerable, because actually the help that they need is much more complex than they're able to offer.
Okay, Alan, are you...
Happy enough, Chair.
Thank you. Colin?
Thank you. I suppose it's building what Alan said there, and I suppose right car, right person could be not me, not ever. Now, I say that in the sense that there will be things that you have to do, but obviously you're there doing work that you shouldn't have to do, and you're there for long periods of time because of the delay in the system. And I think Alan asked a really key question there, which is, what other cases have you not got to because your officers are tied up in hospitals and tied up doing health service work? But is it not a bit, I suppose, a bit of a pipe dream to think that any of this can be sorted out? Because the budget that you have in the place and the budget that the health service has, which 3 of the 5 parties that are present here today voted through, doesn't give you the resources to be able to do your work, but it also doesn't give the health service the resources to be able to do the work that they need to do. So if you're saying that there's this huge body of work that you shouldn't be doing, but you're having to do it, and the health service is saying we don't have the staff to be able to do it, that's why we are leaving it to you. And then right outside the door, while you and the health service are having a fight about who should be doing it, there's ambulances queuing up because they can't get in because there's not enough staff in through the door to be able to take the people out of the ambulances. So if you're not going to do it, health service can't do it, and the ambulance service can't do it, who is going to do it? We draft a few MLAs in that voted for the budget to come down and help you.
Yeah, no, it's a really valid and important question.
I'm glad you said so, because there was tuts there, so I'm glad that you think it's a valid question.
No, I think it's a very valid question in terms of the who. So one of the things that we've done in our data collection, and I'll not go into too much detail on it, but it's to help inform the conversation with health partners, is so in terms of those concerns for safety calls, we've taken a sort of dip sample of a reasonable proportion of them that we could, in effect, escalate up to give us a kind of sense of what this might mean overall. I think I said in my opening remarks that this feels a lot of work for policing, but regardless, a significant proportion of it we will still be absolutely going to, because the risk of harm to the individual or to others is so high. So please, I couldn't be any more clear in saying that at that high end the police will still be going, because we've got the skills and everything to do it. But there is a proportion where we don't. and we're not the right people to go. When we kind of did that bit of work and we applied the sort of right care, right person principles to it, so of that kind of, we'll say 40,000 calls that would come through to us, and this isn't all from healthcare facilities, some from the public as well. Probably about a quarter of it we don't go to already. Okay, so it's triage on the phone, the police don't need to go, and it is signposted elsewhere. When we looked at it, of that kind of 75%-ish that remains, probably at least half of that we would still be going to. It's that other proportion, that chunk I talked about, that we're saying we're maybe not best placed to do that. And, when you look at that, we looked at it across maybe mental health teams and social services, it's perhaps 2 incidents in a day, or 3 in hospitals, slightly more in the region of 10 to 15 for the ambulance service per day regionally. But that might not sound a lot, but when you add all that up and take it out of the demand on policing, that is significant for us. But when you spread the jam across all the parts of health, I don't think it actually is so. So I kind of want to give you some comfort in the sense that this isn't, as I said from the start, the police saying we're doing none of this work. Actually, we're still going to be doing a lot of it. But even if we could reduce the amount by 20-25% from the overall total at present, that would make an incredible difference for the ability of the police to be spending more time visibly in communities dealing with crime.
Also for the individuals.
And that's about 3,000 calls then, just going with your figures there. So who does those 3,000 calls if the health services work in the capacity? Ambulances are queued up outside the hospitals as it is, so they can't do it. Who's going to do those 3,000 calls if you're saying we're doing it, it shouldn't be us?
But this is what we will work through in terms of different ways of working it, because actually some of this is about so sometimes we become the insurance policy. Okay, so if there is a sense of relatively minor risk about someone, so say they walked out of ED, okay, because the ED is really busy, no one in ED's time to go looking for them or inquiring or ring the family. What do? They call the police, and actually the person's just gone to the shop within the Royal, and that's kind of very real life every day. So that, nobody here would say that is right, and nobody would say that's a good use of police time. Those are the kind of things. This isn't about saying we're stacking loads of work back on health necessarily. There are things where people need support and help, and we need to build those pathways. We need to make sure it's all done well. But there's a lot of this other work that is simply about finding a way of saying, just think before you pick the phone up to call the police on this one. I know you have done, traditionally, but actually just have a think about it before you call us, because here's what the police do.
There's certainly some very stark examples within the presentation that you served us in our papers, and I don't think anybody in this room either thinks it's acceptable or the best use of time for the police to be used as an ambulance service 900 times a month. And that's the thing that has struck me most about this. I have one final question, and until I get through this, I'm not making eye contact with anybody else. So I'm going to call for Diane Dodds, who's got questions around finance, and then that's the end of this session. Thank you.
Thank you, Joanne. So it follows on a little bit from what Colin was saying there. I think that one of the problems with this at the start is that it was announced almost by the PSNI as a cost-cutting and saving measure, rather than trying to direct people to an appropriate service. And I am glad that I have joined the conversation today, and I feel much more reassured by it. So that's number one. But number two is when we look at the voluntary and community sector, in terms of health, all of the grants have been cut by 50%. They remain cut by 50%. When we look at hospital staff and hospital capacity, that is hugely overused and really bunged. It's really difficult to get a place on a ward now, and particularly in the Southern Trust area that I know well. So what is the funding stream that we're looking at? And in England and other areas where this has come in, has there been additional funding to try to meet the need? I get it, Ryan, we're not meeting people's need now. I get that. But neither, I'm not sure that I've seen any evidence of any creation of additional capacity and funding in the system.
Okay, thanks, Diane. I suppose the first thing just to say is and listen, it's Ryan and Gary and Una have been kind of leading this from the PSNI perspective, and never have I said that this is about demand reduction for PSNI. It's been, I think it kind of has been reported that from time to time, and some of this is maybe taking what comes from the kind of national press coverage around it maybe 2-3 years ago, and that's all worked through, and it's done so much, it's done very collaboratively, and there is a great consensus around it. So I just want to be really, really clear that from the very first moment I've started talking about this, I've talked about the need to do it collaboratively, and I've talked about the need to have vulnerable people at the heart of it. So I hope that comes across, Diane, because it isn't simply about reducing demand. Of course, we want to increase the ability for the police to do more policing, and our resources to be focused on doing more policing and less health-based work. I think that's totally valid to say that. I think everyone likes to see us doing more of that, but absolutely the person has to be the heart of it. In terms of the funding, I hope you've picked up from what I've said that some of this is absolutely not about funding. Some of it is about operational leaders rolling their sleeves up, getting close to the tools in the key areas such as emergency departments where this absolutely happens, and taking control and showing leadership, and putting in place the processes and policy to help their frontline staff work their way collaboratively and well through some of the chaos that's within there. I'm absolutely convinced that is a part to play in this, and I know, talking to the Royal Colleges, they think it as well, because they want to roll their sleeves up and get involved in this work too. So that makes me feel really encouraged about the ability to be able to achieve something and make some real progress, not reliant on money. This work should, I hope, really amplify where the blocks and gaps in the system are, and collectively allow us to say, from a transformative point of view, if there is a need for more, can we collectively do that together? Can we jointly contribute to maybe ways of doing some of this differently? But those are all future conversations, because the money, if we talk about money at the start, we'd never do anything. And actually, collectively, we've got, in the police, we've got 6,200 police officers who want to do their best job. And health professionals operationally want to do their best by people. I want to help them, enable them, lead them to help them to do it. And I think focusing entirely on money, it means we're kind of giving up before we've even started, and I think we should be starting.
I suspect a lot of this actually could be a reallocation of money.
Chair, can I come back in there? Yeah.
Go ahead, Diane.
So, and I accept entirely that we've got to start the conversation somewhere. I accept that. That's not an issue for me. And I accept also that probably some of the public thought around this process, it was kind of driven by announcements by the Met Police and the national media, etc., as you say, 2 or 3 years ago. And it's right to do it in person. But we don't have enough facilities, and we don't, within the health service that currently stands, have enough capacity at the moment. So some of the reasons for the blockage of people who are very, very vulnerable in our ED departments is because it's really difficult to find the appropriate placement for them. And I don't think that we can escape the issue of funding. I just don't think we can escape that. Now, that might be reallocation of funding or reprioritization of existing funding. I'm happy to accept that, but I don't think that we can escape it either. And I don't think that we'll work out practically pathways forward unless we look at that as well. We have a mental health strategy that doesn't have anywhere near the funding that it needs to be complete. Not even coming close to it at this minute in time. And I don't think that we can escape that conversation.
No, I think you're absolutely right. I think that conversation will have to be had, and I presume it's part of your work. And some of those issues are also issues we'll follow up with DOH, because I suspect that if some work is done upstream, and if people with mental health crises are served in a different way, they may not be presenting in A&E, and so it's just about a redistribution and making sure people are in the right place to get the right care.
I'd just make a comment as well. I'd just like to reiterate again, yes, to some extent, but I would agree with yourself. It's cultural change and it's leadership that makes the biggest difference. And I think It's about maximising our resources more effectively and collaborating together and how we can do better. And I would also commend yourselves in relation to the compassionate approach that you are currently making when you are getting these phone calls, because if you weren't responding in the way that you were responding, there would be far more hurt and pain within our local homes and not the support of our people. So it's a way, I critically, I think, leadership and having a compassionate approach to people as two key areas alongside any additional investment. And it has been done when it comes to family support hubs with nominal money, but it was leadership that was shown, and it was collaborative approach that are on the ground supporting our families and providing that early intervention.
I think ultimately the bottom line here is that we all want to see circumstances where if somebody finds themselves in this position or a family member in this position, that they're being dealt with by the right people in the right place at the right time, regardless of where that is. People need to be receiving what they need in the best way, and I think that that's to the benefit of all society, and that'll be a win for the person, it'll be a win for their families, it'll be a win for the police, but it'll also be a win for the Department of Health and so on. So that's, I think, where we need to be, and those people need to be the focus. So with that, can I thank you all very much for your evidence. I trust that at some stage you will follow up with us. I had some questions myself, but we'll forgo that. If you could follow up with us, please, Ryan, around Matt and the community safety hubs and updates as to where that is, because I know for a time funding for that was under threat. I'd also like if you would follow up with me in writing, please, around the challenges thus far. Now, it might take some time, but I appreciate we've got some examples of what has happened in the past. But and you may have just started work with colleagues from other departments on this, but the challenges thus far with regard to partnership working and how you'll intend to iron some of those out. Ciara's questions around the community and voluntary sector, and Alan's issue around ombudsman's cases. I think this is a particularly important part of the work, because police officers are finding themselves under investigation for responsibility that isn't necessarily theirs, and where really there's no investigation to be had, but it has to be done because of process.
And I should have said and didn't, and just very quickly on that point, the Police Ombudsman's Office do not want to be doing this work either, and they are involved with us because for them they want to see better policy and guidance and all of everything we've discussed, because they realise that it's putting people in a very difficult position, but they are required under their obligations to do it.
That's hanging over people who were trying to do their best, and would make them reticent to help in future. So all of these are issues, I think, that, I mean, you can see people are very engaged in this issue and very interested. So hence the time frame. But thank you for your evidence thus far. No doubt there's some issues we will wish to follow up on, but in the meantime, there are some, if you could come back to us in writing, it would be really helpful. In the meantime, can I thank you all very much for your attendance today and your candour. It's greatly appreciated.
Listen, thank you, and I really appreciate your engagement and questions and interest in the topic, so thank you all very much. Thank you.
Members, can I seek your agreement to note the paper from the PSNI? Thank you. Agenda item 4 then is right care, right person and collaborative working, and we're going to have evidence from the Department of Justice and the Department of Health. Could I ask you to turn to pages 35 to 62 of your meeting pack while the officials get themselves seated and relaxed. Members, just could I really emphasise, we really need to be concise in our questioning if we can, and really limit the preamble, because I want people to get a chance to ask their questions, you know, and tease out their issues without the whole explanation that may not be required. Sometimes it is, but
I'll keep mine very concise. I want to get home before 9 o'clock. Won't have to lift my child. It isn't looking likely.
No, it is. I'm just really conscious that people have waited for a long time. And if we're talking about use of people's time, it's not great to have people sitting over. But I don't want to curtail conversations either. These are not small areas. very welcome, everybody. Let me just introduce you to the committees. So from the Department of Justice, we have Julie Wilson, the Head of the Victim Support Division, and Mark Goodfellow, the Director of Safer Communities. And from the Department of Health, we have Peter Toogood, who's the Deputy Secretary for Social Care, and Caroline Hickey, who's the Head of Criminal Justice Healthcare Policy. Folks, you're all very welcome. Could I apologise to you that we've kept you waiting and we're running so far behind time, but thank you very much for your forbearance, and you'll appreciate that members are significantly interested in this topic, and probably far better to have engaged members than people who are not so. So thank you. Peter, it's been a long time. I'm sure it's more than 30 years, but it's nice to see you.
Likewise, you haven't changed.
Likewise. So, I don't know if you folks have anything that you wish to say in advance, or if you wish to just turn to the paper. You do have things, Mark, yes?
Yeah, with some introductory comments,
well, then,
Chair,
I will
if
hand
that's
over
okay.
to you for your introductory remarks, and then we'll move on from there. Thank you.
Brilliant. Thank you so much. I don't need to apologise, because I think we all find it incredibly reassuring, actually, that there is this level of engagement in this issue. So thank you for that, and thank you for the opportunity to brief both committees on the Right Care, Right Person initiative. You've helpfully done the introductions, Chair, so I'll dispense with those. RCRP, as I will call it, so Right Care, Right Person, so forgive me, I'll try and make sure I only use that once just to save a bit of time. That's the focus of the session today. I'm conscious that we have shared with both committees a really long list of other areas of collaboration. More than happy, clearly, to try and pick up on some of those if members would like. Equally, you would appreciate to have enough officials to cover all of those areas. Would need to move into the other chamber, I suspect, to cover that. So it may be that we need to come back to you, but more than happy to do that. You've heard from Ryan, from Gary, and from Una in terms of the impact that RCRP could have both on police resources and in terms of what we would hope to achieve by the introduction of the initiative, so I won't repeat any of that in the interests of time. As you've heard, it will be a considerable ask and a considerable task for everyone, for PSNI, for health service colleagues, and for a range of business areas. And that's why I think it's really, really important that we have that high-level, senior-level oversight that Peter and I jointly chair across both Departments of Justice and Department of Health. Because this has got to be about the person at the end of that call. So that has to be our absolute focus. So I think it's really important for Peter and I to emphasise for committee members, and I'm conscious that Ryan did this to some degree. Peter and I are going to lead the Strategic Oversight Group in a way that recognises what RCRP is, but equally as importantly for me, recognises what it is not. So what it is absolutely not is a territorial battle between health and justice. It's absolutely not about a territorial battle between police and health service. What it absolutely is about is making sure that the right intervention is provided for that person at the right time by the right organisation. So this has got to be the only lens through which we see that. That will drive out efficiencies, and that's to be welcome, but it can't be the primary driver for all of this. And the needs of the individual will be paramount, and I also want to reassure committee members that, as Ryan said, this is not about an exit strategy by the PSNI. There will be occasions where it's absolutely right and proper that the PSNI is in attendance, and where those occasions exist, the PSNI will be there every single time. So I just want to provide that level of reassurance for colleagues. The other issue that I want to reinforce is the issue of operational independence that was touched upon by colleagues. To be absolutely clear, none of us at this table will seek to compromise the operational independence of the Chief Constable and the PSNI. Absolutely not. As you heard already, in theory, PSNI could have run away with RCRP and done this under the banner of their operational independence. I think Peter and I find it hugely reassuring that they chose not to do that. They proactively chose to come to us and try and do this in a collaborative way, in a managed way, in a way that all organisations can be ready for implementation. So where does that leave the Strategic Oversight Group? And some members helpfully picked up on this issue. I think Peter and I would see the role of the Strategic Oversight Group to provide that strategic support at departmental level, at policy level, at legislative level. The Strategic Oversight Group affords us the opportunity to spot the interdependencies, to be really mindful of the unintended consequences,
And when the silver level group that you heard about starts to make operational recommendations and decisions, where those decisions and recommendations carry with it implications for policy or legislation, that's where Peter and I can make sure that the dots are joined, and we can make sure that both departments are ready to give those decisions effect. Ryan mentioned this as well, but I do want to emphasise it. This is not an off-the-shelf product. It's not a lift and shift from any of the 43 constabularies that you heard about. This has got to be Northern Ireland centric. It's got to recognise our specific needs, our specific operating landscape. Peter and I have already met with some colleagues across some constabularies in England and Wales just to try and tease out some of the very issues that members have raised here today. What are the lessons? If it's gone wrong, why did it go wrong? What can we learn from? So there's some really good early learning that we're picking up, which tells us what not to do, and importantly tells us what to do to get this right for the circumstances that we live in Northern Ireland. Just a couple of things in closing, and this might pick up some of the themes that colleagues were questioning. There were questions around the timeline, a clear theme around resourcing, and some questions around the terms of reference. So we are at the very early stages. Peter and I chaired the first meeting of the Strategic Oversight Group last week. The terms of reference we will share, as we said, with committee members. One of the specific areas in the terms of reference is a timeline, and the reference there talks about Peter and I making sure that there's a timeline agreed, that all colleagues and all organisations have a state of readiness. So back to your point, Danny. So we want to be ambitious with this, but we want to be ambitious within the constraints that every organisation has to be ready, because we don't want to leave anybody falling between the cracks. So that will be critically important to us. I think on the issue of resources, and I completely agree, resources are going to be a constraint. I've no doubt about that, but I don't think they're going to be an absolute showstopper for right care, right person. And I say that because I absolutely support Ryan's view that there's stuff that can happen operationally at a local level. It can be communication, it can be leadership, it can be just getting the right messages across. But I think also for Peter and I, there's a challenge in terms of, are we making the best use of the existing resources we have? So if you take at a very practical level the ED example, that is always the example that comes up here. I don't think it's as binary as, do the PSNI stay with the individual or do they hand it over to the health service? As part of a phased implementation process, I could see something that says, but there could be a point where you have a soft handover, a soft but a safe handover. So the police might present an ED with someone who presents risk of harm to themselves or to others, but over a period of time, whilst they're waiting, that risk could dissipate. So can we effect a soft, safe handover to other people? We haven't yet had the discussion in terms of who that might be, but I know others have come to us and said, what about youth workers? What about community safety wardens? What about street pastors where PSNI would routinely, as part of the nighttime economy, go to that community-based resource care that you spoke about and say, actually, sometimes the last thing you need is 2 armed police officers going in. If you had a community safety warden or a street pastor who may be able to de-escalate, provide some support, and that could be a soft handover point. So I think there are creative opportunities that we just need to think about where there are existing resources that would not carry an additional huge resource burden on us. The final point I would make, Chair, by way of introductory comment, is that we touched upon cautery and we touched upon engagement with Charles Little. I'd just like to put on record, on behalf of Peter and I, our huge respect for the work that Charles and Wendy are doing. He has been incredibly generous with his time, with Peter and I, both in relation to cautery and as we develop the work on this. We engage with Charles not to tick a box, but actually we go at the end of every single cautery task and finish group. Peter and I go and meet with him and with Wendy, and we talk through the issues. We get his perspective, because the last thing in the world that we want to do is a bunch of suits trying to create the right solutions without talking to people with lived experience, service user, and Charles and Wendy have been incredibly gracious and generous with their time. So I would like to put that on record, if that's okay. And I'm going to stop there because I'm conscious we're way over, but Peter, you have a few comments to add?
Just a couple of comments. Thank you, Mark. Thank you, chairs, for the invite today. I'm not going to go through what I actually wrote because a lot of it's been talked about already, which is encouraging, but I want to draw out 2 issues to emphasise the importance and how critical they are in terms of the work that Mark and I are overseeing. We've heard a lot today about having people at the centre of this service and or this proposition of RCRP. We've talked a lot about how vulnerable the people are that we are serving collectively. And we've talked a lot about making sure those people don't fall between the gaps, and they can't be the victim or a consequence of organisations working out who goes where and who does what. So that's at the forefront of Mark and my consideration as we chair these oversight arrangements. You know, these people are vulnerable and they will be at the centre, and we talked about neighbourhood involvement. People with lived experience are going to be key to informing the work that we do. That includes service users, but not all service users are people with lived experience, and that will be a key part of that. RCRP is an opportunity to do something differently. We've heard today things aren't working, so this is good. We do welcome the fact the police have brought this to us, and we will work with them in that regard. I do want to just set the work on RCRP quickly in the context of the broader work we're doing. Both permanent secretaries are fully engaged on making sure that our 2 departments work better together. So you'll see your paper that we provided, the 40 or so areas that we've pulled out where we are working together. Both Peter May and Hugh Wittes are committed to working. We have an arrangement with them where we will sit down now and look at the key interfaces, have a deep dive maybe into some of them to understand, is it working well, how does it link with the other work, and just to make sure that health and justice interface is working as seamlessly as possible. In terms of the work that Mark and I are doing, we've talked about the work on Caudry. We're modelling the oversight arrangements for RCRP on the work we're doing in relation to the Caudry Inquest and the recommendations coming out of that and the work we're doing there. That's really working quite well, and there's some really encouraging collaboratively designed products that are going to come out of that over the next number of months. And we've also built that on learning from colleagues in Wales. They had a national partnership group which was very much led by government and departments as well as the operational side. So we're confident that what we have provides the basis to deliver the change that's needed. So I suppose what we want to leave you with a flavour with is through what you've heard today, through our papers, hopefully through our opening remarks, that we're committed to working together to make that interface as seamless as possible. And we're happy now just to take and explore some of those issues further. So thank you.
That's great. Thank you very much. First of all, I'm going to hand over to Liz.
Thank you, Chair, and thank you both. I know it's been quite a long session. I only have one question because I know colleagues probably want to pick up on other areas. And it may or may not be related to some of the work that you have been doing, but it is an issue, I think, that is symptomatic of that kind of need for that real joint working between the 2 departments, and it's in relation to remand prisoners and health input. And an issue that's been coming up probably more and more for me that I've been dealing with in terms of constituents is people who are consistently being picked up in the justice system. They're being going into remand, serious mental health and or addiction issues. They don't get the support that they need in there because obviously I don't think it's provided, and just I suppose what I want to tease out. And then they're released, they're not sentenced given the nature of maybe why they've been picked up in the first place, and we're back into a vicious cycle. I've had one case where a man has actually died just because everything had just deteriorated further. And I just think there's a real opportunity there in terms of rehabilitation, of keeping people out of the justice system, but actually tackling those core issues of why they're in there in the first place. So you may or may not be able to, I know I'm kind of jumping a wee bit across from the right car, right person, but I think it does tie in with the basis of our conversation. So if there's anything you can provide in terms of what the current processes are, and if there's anything looking at that going forward, try and improve that, because I think it would certainly help keep people out of remand custody, and out of the justice system and get the help they need. So I know it's a wee bit long-winded, but just to kind of explain where I'm coming from.
Yes, Caroline leads on a lot of our health and criminal justice work and can speak to some of that.
Yes, a bit, not vastly. It's more with DOJ, the remand population. the remand population in Northern Ireland is really high, and that causes problems across the board. It causes problems in healthcare in prison as well, because obviously everybody coming in has to be assessed and they need the healthcare that they get. And there is, it does go round in circles a bit. But I am aware DOJ are they're looking at a bail project at the minute, which would be on remand, I believe. And I believe there was a workshop on it this week. What I would say, it is collaborative. SPPG within the Department of Health and PHA were represented at the workshop, but I don't have details any further than that.
No, thank you. And thank you, Chair. I suppose I know it is a wee bit off topic, but I think it's a good opportunity to raise it with everyone in the room. I think there's a real opportunity there, and I've seen some really sad cases of people who are just consistently in that system, in that cycle. They then just leave. There's no support when they get out because they're not known to anybody. And generally speaking, the police who are dealing with maybe these people on a frequent basis, they know what the issues are. Generally, it's because they're under the influence that their behaviour has led them to be in remand. They're never, I've dealt with families who are nearly hoping that their loved one will be sentenced to get them the help they need, which is a very sad state of affairs. So appreciate that, and it's something I might pick up at another stage as well. But thank you, and thank you, Chair.
Thank you very much. Thank you. Actually, with regard to the prisons and remand issue, I know certainly Stuart had questions in that area, and so did I. So I'll go to you now, Stuart.
Yeah, with regards to remand, and Joanne will remember that she and I both met a very distressing set of circumstances when we had a visit to McGalbury Prison. Clearly, the individual that we met with should never be there, but it was the only place that they could be looked after, and they were being genuinely looked after with the most incredible care and compassion by prison staff. But clearly, the reality was that individual should have been in a mental health care facility, not in prison. So, apart from, a lot of the discussion today has been about EDs and the immediate issues that both police and health professionals face at that point in time, but there are also the long-term issues as well. And just exactly how will this project, or further emanations of this project, deal with those more long-term issues?
And I think, Stuart, remand is just a huge problem in Northern Ireland. The proportion of prisoners on remand is way significantly higher than we want, and we do have that perfect storm where the provision of healthcare within prison is for health, but prison officers are doing the day and daily stuff. I know if Beverly Wall was here as DG of prisons, she would share with members that they have been really proactive within prison service at rolling out mental health first aid training for officers, but that can only deal with the tip of the iceberg. They are not mental health professionals, but there is an attempt to start to fill that gap alongside the good work that the Trust does within that. So I think some of the things that might come out of the work that Peter and I lead to will absolutely need to recognise that whilst we talk about ED as one example, people in prison are members of our community. Prisons are a microcosm of society to some degree, so we need to not lose sight of that and how we can try and get upstream and ahead of that, so before they come in to try and deal with the mental health crisis, because you're right, prisons is not the place to deal with that, and at that stage you're left doing what you can, but with a very, very limited resource. But so I think the only reassurance I can provide at this point in time is the work that prisons are delivering to provide that mental health first aid training. We discussed actually at the Strategic Oversight Group last week the work that police have done to roll out mental health first aid training, and extending that out to the ambulance service, and I think that's the benefit of having a number of partner agencies in the room. Sometimes I don't know what I don't know, and then ambulance service comes in and says, actually, can we avail of that training? And so I think that the prisons piece is absolutely something we'll need to keep on radar for this.
No, and it probably plays into a lot of what was discussed earlier. In Northern Ireland we need a proper and functioning regional mental health crisis service, and there's a lot of work going on in that regard at the moment, and that's critical to the success of our CRP, because that delivers the pathways and the facilities and the working ways into which we can best support people. Because if we get in at the right time, then we get the right support, and people don't end up getting either arrested or going to the wrong facility in its broadest sense. I mean, I'll give you an example. The ambulance service have been working with the South Eastern Trust and having mental health practitioners in the ambulance control room. So whenever calls are coming in, they're getting an informed and clinical view as to how best to triage that. And that has seen a 40% reduction in conveyances to the ED over the period that they've been doing that. So that's a good example of people not going to a place, but I presume getting treated and addressed in the right place, in the proper place. And you magnify that up if that person's not going to ED or getting distressed, causing a rumpus, getting arrested, etc. So it all fits in together.
And very briefly, how does that fit with data sharing and information sharing between police and health? Because thinking again of that individual, the reason they ended up in prison was because they had committed an assault against a police officer. But the reality was, if you roll back in time, that assault would never have happened if it had been an appropriate mental health intervention, perhaps weeks, months, days, hours, or even years previously.
And that's at the crux of this work that we're trying to do. So at the moment, I don't have a specific answer on the challenges around that, but that's certainly the Silver Group that has been tasked with developing the implementation plan will need to consider at what point is that, do we need to tackle that? At what point is that a real inhibitor? Ryan talked a lot about a lot of what we want to do in the first instance is just how we work better together. Are we clear on our roles and responsibilities? That's where the work of the Cadre group is really good at trying to help clarify what our respective roles of the police and health service professionals are. Because when you're clear in that, then you're talking, then you understand, well, I have to do this, I have to do that. And we don't have people falling in between the gap, and that information is sharing, I suppose, either informally, and sometimes, yes, that needs to happen formally as well.
And I think, Stuart, just to close the point, because I think what you're talking about goes beyond Department of Health and Department of Justice and PSNI, because as you say, if you need that upstream early intervention months and sometimes years in advance, actually we need education in the room, we probably need communities, and because people, I tend to work on the basis that people aren't born to commit crime. There's a socio-economic set of pathways there, whether that's a housing challenge, an employment challenge, a relationship challenge, a mental health, a substance and abuse. So I think there's a wider piece here for the wider approach to community safety in Northern Ireland that goes slightly beyond this group, but we shouldn't lose sight of it in this group either.
The involvement of the voluntary and community sector is vital in all this, and it begs some very fundamental questions. When does somebody who hasn't got the mental capacity to know that they've broken the law is dealt with under the law rather than under healthcare?
I'm going to come in on kind of the back of a couple of Stuart's points, and some of it is not questions, some of it is stuff that I want to put on your radar on the basis of the papers that you've presented of joint working, because I think that within that, I think that there are some gaps. As you said, Mark, I think it's beyond mental health at times. There are just people in prison who shouldn't be there. Some because of their mental illness, and there are issues around, and this is an issue for the Department of Health, I think, there are issues around personality disorder not being in the legislation, so that's one factor. The other issue is that prisons are not care homes, and there are a number of considerably elderly people in prison for relatively minor crimes where prison officers are having to operate as carers, where they're having to wash people, take care of their hygiene needs and so on. And I mean, there are dignity issues there, I think, for all concerned. Those people are not trained for that. So that falls into it. With regard to prison. But also there's the issues Stuart raises about information sharing, and something that we're hearing consistently from prisons is with regard to one, medication. So, and actually health backgrounds. So what we're hearing from the prison service is that when somebody comes into prison, the only kind of background that the prison service will receive on them in terms of their health in general is what the prisoner chooses to tell them, because information from the Department of Health or their GP, etc., will not be shared on the basis of client confidentiality. Likewise, medication. So we know that health trusts are embedded within prisons and they're responsible for medications, but we also know that a number of prisoners are responsible for their own medication and are allowed to keep their own medication. And all of that is fine, except for circumstances where, one, medication can become currency. Two, prison officers are not entitled to know, one, the list of medications that any given prisoner is on, and two, how much of it they hold. Therefore, from a prison service perspective, how are they, one, able to manage the amount of drugs within a prison environment? Two, they have no concept as to what an individual prisoner's baseline is to know whether or not they are trading their medication, whether other prisoners are on it. And actually what this results in is the prison officers fighting the battle on drugs with one hand tied behind their back, but for the prisoner's well-being. And I'm conscious that this entire conversation should not be about prisoners, because there's a lot of people outside of prison who really could do with much better care in general. But from a prisoner's point of view and from their well-being, it's not helpful necessarily for prison officers not to know what their baseline is. So how do we find the balance and have a proper conversation around information sharing with regard to background and so on? And things like speech and language therapy, we know that many prisoners end up in there because they've had communication issues in their childhood, adverse experiences and so on. So how is all of that handled when prison service doesn't know what the background is, and then they will maybe behave with people in a different way, or could behave in a different way if they had the knowledge? So where's the balance to be struck in the course of your work, and is it on your radar, between confidentiality to which a patient is entitled, but also safeguarding their well-being, because the people in charge of them should have a knowledge as to what's really going on beneath the surface?
Okay, thank you, and I'll let Peter and Caroline come in on that one. I mean, I know that the healthcare and prison team does comprise multidisciplinary representatives that I would hope would negate some of the scenarios that you have helpfully highlighted, Chair. But Caroline, do you want to pick it up?
Yeah, I'll do them in reverse order to what you did, Joanne, to be fair.
Apologies for not making eye contact.
No, you're okay.
Other members were indicating they wanted in on this. Thank you.
No, it's absolutely fine. So on medication and data sharing, just covered as data sharing, I think there's an action within the Improving Health and Criminal Justice for better data sharing across all organisations in the criminal justice, including health. The focus on that one at the minute is in prisons, and I believe we are very, very, very nearly there in terms of the implementation of that data agreement. I think, I'm trying to work out who I had my last conversation with. I think it was actually NIPS, and I believe, yes, it's nearly there in terms of implementation. There is data flowing from the South Eastern Trust onto the PRISM data set, which is the one that's owned by NIPS, so it's onto their data. At the minute, it's done on a consent basis, so unless the person in prison has given their consent for the information to be shared, and that is covered at the minute until the data sharing agreement is fully signed off to protect against data protection. So it is an issue. All of the issues you've raised there are actually very much on the radar, and that one is definitely being worked on, and I do believe we're nearly there, but I can also come back to you with more information if you need it on that. Social care in prison we've been talking about for a long time, in fairness, between the two departments. There is an increase in number of older people in prison. There is also an increase in the number of people with more complex needs, that may need personal care and things like that. About a year or two ago, we set up a task and finish group between the two departments, which had representation on it from Probation, South Eastern Trust, obviously the Department of Health, Department of Justice, NIPS, some of the governors, and we discussed it there. It got so far, and we're now re-looking at it. What health are looking to do is to do some sort of a needs assessment in the prison to see what the need is for personal care, to work out how we can commission and provide that provision better. So that is that one. I'm doing these very quickly because I
No,
think
it's
we're
fine.
short of time.
Actually, some
So
of that is
just
about
stop me if
sentencing
I'm.
too, you know.
And personality disorder, yes, that is raised to us frequently by both NIPS and South Eastern Trust staff. We are aware of those issues. It's different from the UK where it's included in their mental health order or act. I'm not sure which one it is. It's a mental health order here. We will look at it, and I think there's a bit of a scoping exercise going on looking at our Mental Capacity Act, and it may be something that we take forward in the next legislative change there. Also, just in terms of general collaborative working, we have set up a group. Well, we're in the beginnings of setting up a group. We met for the first time last month, and we're meeting again this month, between health officials, SPPG, PHA, prisoner governors and directors in headquarters of NIPS, where literally the last meeting we did sort of sit down and go, what are all the big ticket items that we need to be looking at, and we will develop that. We're also re-looking at our partnership agreements. So I think even though collaborative working is good, and it is good on the ground within prisons between both prison officers and healthcare staff, we are looking to make progress in that area as well.
No, do you know what, Caroline? It's great to hear that all that stuff's there. It's great to hear that you're nearly there about information sharing. But I think this has been a concern, I think, for all of us for a long time. That we say we're aware of the projects that have been cited in the papers, and many of us have seen them and visited them. The issue just is we've never been really clear the extent to which there's collaborative working much further up the chain and more strategically. So it's really helpful to have this concurrent meeting. So thank you for that. I know that Ciara's got a specific question on this issue too.
It's just adding on from obviously medicine, etc., etc. Big issue for me, and that I've been spending a lot of time, is parents of vulnerable young people who are arrested and are put in McGarry or McGilligan, and I'm having to constantly liaise on behalf of, because there's no communication. They know their child. They may be an adult and over 18, but they're actually a child in their parents' eyes, given the range of learning disabilities, etc., that they have. So I'm just wondering, has that been looked at as well, and how that can be improved? I know McGarry do have a family support service and they can ring, but it can be quite time consuming before a family actually is able to liaise with them. McGilligan, it seems to be non-existent. There's nothing. So is that going to be looked at as well?
Not 100% sure of that one. What I would say is the South Eastern Trust are actually really good, and you know, normally if we get correspondence in from yourselves to ourselves, you know, the advice is ring the South Eastern Trust, ring the healthcare and prison team, and they will try their best to get the consent of the person to provide the information they need, and they will do what they can on those issues.
I think, Ciara, when we can look at that in more detail, and I will certainly talk with Beverly and NIPS. I've seen examples in other jurisdictions where, for example, if my loved one, my child, my whatever wife, husband, partner is brought into custody, there's a recognition that actually Mark's next of kin knows his trigger points, knows his motivations, and if there was a way to have that safe space conversation between the authorities and the next of kin, that could short circuit what might otherwise take prison officers weeks or months to develop that level of trust and confidence. So I think there are examples that we can pick up as part of this work.
That'd be good. Well, thank you.
Thank you, Ciara. Linda, you've got stuff around the DOH's plans. Well, when I was writing it down really quickly in shorthand, it was right. You had issues around what the DOH was planning to do and some of this stuff.
Yeah, so I'm gonna try and keep it as succinct as I can. There's a million questions I can ask, but I'm not doing that on you or the other people in this committee. I suppose one of the things for me, Peter, I'm on the policing board, so declare that as an interest. So this is a real bugbear for me, is policing picking up stuff that is clearly health. And it's not because I think that the police should be protected from having to do it, it's because it does not get the best outcomes. So for me, it's what are the measurements going to be coming out of this work? So are we just going to measure the reduced calls for PSNI, because that's not a measurement of the outcome for the person? So how are health actually going to measure this? You know, are health going to measure it by how much extra it's cost us and how much extra work has come to us? And police are going to, I'm not asked what the police are going to do, but the reduced calls. So this isn't for police, this is for you. What is the improvement in outcomes? And where have these people not then turned up in the system in other places, not turned up at A&E because the right person actually responded to them at home? So for me, I think that's, and there's a lot of talk about, you know, particularly around the mental health, but we know that very, very often people with particular additional needs will present as mental health, and very often not on the streets, not out there being arrested by the police, but actually in residential settings, in healthcare settings, their police are being called. So I'm talking about places like Muckamore. We actually had one case where a spitting backyard was used on a person. So, and I've had cases of people coming to me with elderly people in residential care. I mean, I'm talking about people who are 7 stone weight, you know, not fit to look after themselves, but staff are calling the police to deal with them. So we really need to get a grip of this, and health need to look at what are the better outcomes, and our people, because it looks like a duck, quacks like a duck, it's a duck, that the people are actually using police. Just, I can't be bothered, you know, or they're not being trained properly. So not all of this will be resource intensive. Some of it is really about good training, proper training, making sure that people understand their role in their job, and ensuring where something like that happens, where police are called to a residential care setting. I mean, I think the police should be able to contact immediately the health service and say, there's a problem here. This residential care setting cannot look after your patient. So I think that, you know, that stuff needs to be looked at. So it's about the measurements. What are we going to see in terms of measurements coming out of this?
I'll start on that one, Linda, thank you. When we were looking at this, one phrase struck me. It was the Royal College of Psychiatrists, and what they said in relation to RCRP was success will be measured by the impact on people, not by how much time it saves the police. So to me, that's gone through the discussion today, and to me, that's cracking that is and keeping that at the forefront is going to be important. So what Mark and I will expect and we'll be monitoring is as and when the conversation develops and the plan is developed as to what we're going to look at in terms of what the Silver Group are going to propose as this is because it's going to be a phased implementation. We're going to do it piece by piece, but at each stage we will expect to see a performance and management framework to use the civil service speak about that, but that will be very much focused on what's going to be different here. There will be a resource element of it. There will be if you think of it in the sort of the outcomes-based accountability, how much did we do, how well did we do it, and who's better off? I think that's a really helpful framework around which we will look at the impact of any of the phased implementation of RCRP and how people better off. So there'll need to be ways of capturing that. You know, how much did we do? You can say a 40% reduction or 50% reduction or a movement of you know, that's helpful, but is people better off? And we'll need to capture that. But certainly that will be at the forefront of our considerations in line with what the psychiatrists have said. So was there something else, Linda, actually?
Anything there?
No, I'm happy enough because that's something that I'm just going to keep a really close eye on. So we're not there yet. So there's no point in drilling down into stuff that's not there yet. So I'm okay with that.
No, I suppose the only thing that I would be asking for, Peter, with regard to all of this is, I presume you're going to have to look at the hours of services. You know, and out of hours of services in particular.
Yes.
Because there's no point in any of this if there's nowhere to refer people to. So are you going to be looking at 24/7 models, or what's the plan?
I mean, ultimately, yes, that has to be part of the discussion. A big part of it, and as Ryan was saying earlier, we'll look at how we work better together. There's work coming out of our Quadri work where we've worked on the guidance for the mental health order, and we've looked at a range of supporting guidance and pull that into one document that's absolutely clear. That will help the operational piece. But one of the reasons why, again, pulling out why you can't just lift RCRP from England over to here is we're not structured in the same way in terms of health and social care. So we don't have the alternatives to ED, the crisis suites. You know, it is ED at the moment. Even finding places within ED, I think it was Morris, or maybe it was yourself, Danny, said it's hard to carve out even spaces within ED so we can look at mental health people or those mental health crises properly as well. So it will be part of it, Joanne, but it will be part of the phased implementation, and we'll need to consider that in a way. It plays into the budget discussion that Diane was talking about as well. I think there will be budget implications on this, But that needs to be done from an informed and evidence-based perspective, and I think this work will help get to that point where we're having an informed ask as to this is what we need, this is why we need it, and this is what it'll deliver. So.
Just on the back of that, before I bring in others in other areas, could I check in terms of the evidence base, Peter? Obviously, the police have done considerable amounts of work around what the calls are, who should be doing, that it's not for them and so on. But have you done work inside about the extent to which your department is dependent on the police to pick up the pressures that you're not able to deal with at present?
So we haven't done a data collection exercise in the same way that the police have. But what we have prepared is an impact paper. So on the basis of the information that we know at the moment, what would be the potential impact on health and social care in Northern Ireland? And that paper's been informed by the trusts. The Royal College of Emergency Medicine have contributed to that as well as colleagues in the department and SPPG. So we have I suppose, a corresponding paper of sorts. I suppose because this is a police initiative and they've brought this to the table, we need to understand absolutely what's involved. That's why we're delighted we're working together on this, because there is nervousness. There is this concern that this is just literally going to sort of displace people from one system to another, both systems under huge pressure. So we have a paper which we will share with PSNI, and they will share their data paper with us. That will be considered by our Silver Group in the first instance, and they will use those two documents to help inform what the phased implementation plan will look like.
Very helpful, thank you. On this same topic, I've got Ciara and then Danny.
Just on the same topic, and I did reiterate how vitally important, how gold dust the community involved sector is.
Yeah.
Just in relation to yourself, GP federations, our local pharmacies, our multidisciplinary teams, where do they fit into this?
So again, they're probably... They will fit in as part of, I suppose, our broader work in relation to our mental health crisis service that we're working on, which is will be a bedrock as to how RCRP works. So they'll be involved in that. The other bit of work that's going on in the health sector at the moment is the integrated care system, or the area integrated partnership boards, AIPBs, I think that's what it's called. That's they are locally are based, aligned with our health trust areas, and they involve GP federations, community voluntary sector, our health trusts, to look holistically at the needs of the area that's being served. So it'll be picked up as part of that. The challenge in all this is just docking the operational interdependencies into that work. But I think we have all the building blocks there. We just need to make it real. Say here's an issue we're going to work on, and this is how it's going to fit in. I think we can talk about common guidance, we can talk about everyone being clear on responsibilities, but when the rubber hits the road is when you have a problem or an issue. We need to work that through and dock it into those structures. But yes, community and voluntary sector, GPs will be hugely important in making sure this works, because that's where a lot of the interface still is. Yeah,
I suppose it's essentially who's the champions. You can have loads of kind of leaders and there's nobody championing it and driving it. So I think what you say is where it's docked and how it's driven, that's going to be critically important as well. Absolutely. Because you can everybody has good intentions, but then they're nearly pulled back into day-to-day of the demands. So,
and that's where I see the real value in the work that Mark and I are overseeing, because that's certainly, we have buy-in from both our ministers to say this is the right thing to do. So we have that, I suppose, imprimatur to say, to pull it back and to keep it on track. It's going to be really powerful jointly.
Thank you.
We're on the edge in terms of quorum now. So if anybody else were to leave, and we're carrying on the basis that Linda's returning. If anybody else were to leave the room, in fact, we have no authority to take evidence, never mind make decisions, and we did require to make decisions today. So could I ask people if you could just bear with us till we get through folks' questions, or if you absolutely need to go, can you highlight it to me? Because we've asked officials to wait. They've waited a considerable period, and I think it'd be a real disservice if we didn't wait to hear what they had to say. Is that okay? Thank you very much. Apologies, Mark. I just need to make sure nobody else leaves.
Of course, no, not at all. No, it was just to expand on Peter's point and around the sort of the authority and the champion and how we're going to keep traction, because people will get dragged into their day jobs. It's for that very reason that Peter and I, both with Cautery and with this group, we want to inject a bit of pace. We're going to meet every 6 weeks at absolute outside, and Cottery we meet every single month because we want that constant pace, and people aren't then used to going back in the day jobs and thinking, well, it'll be 2 or 3 months before the next meeting. So I think keeping that discipline on it, meeting on a monthly basis or a 6 weekly basis, progress reports having to come back in, that's quite tight turnaround, but that's the sort of discipline that we want to maintain with this.
And it's embedding, you said it's the day job. This has to be the day job.
Yes.
If we're to do things differently and to change the way we're doing things, this has to be, I suppose, embedded, and that helps us get to that point.
Danny, you wanted to?
Yeah, just briefly, thank you, Chair. Just the previous question I was asking, now I absolutely believe this is the right thing to do, and certainly the system isn't working right at the minute. I am concerned just about the effect, what it will mean on a busy emergency department. You know, when we're talking about levels of assaults, we're talking about levels of incidents. Has there been an assessment of that across the board in GB? And second question was that potential impact paper. Could that be shared with us as well? Or?
Yep. When that is complete, and I'm sure that the PSNI paper would be equally available whenever we finalise that. Danny, I'm not aware of that analysis being done in GB in terms of impact on emergency departments. And again, it depends. It's back to we need to break this down into the series of sequences and steps and what we're going at, because we can't. It is going to mean things are going to be done differently. So we need to do that in a managed way, so we can assess the impact at each time. And again, not every action that we will take will necessarily have an impact on an ED. So it's probably back to the point around how are we going to keep an eye on this, how are we going to monitor it, how are we going to make sure that this is working, and that'll be probably depending on the nature of the intervention or the change that's happened. We will not need to make sure we're capturing the right impact on it. We don't have that. We're not at that stage yet.
And I think, Danny, in terms of, I think there's a clear theme emerging here, and certainly from the first meeting we had last week, which is there needs to be something beyond ED as a defined place of safety. So what are the community provisions that either already exist that we're not utilising, or importantly, where's the gaps that we need to think about? But I think one of the conversations that Peter and I had with Avon and Somerset Constabulary, because it was signposted to us as one of the areas where this has worked incredibly well. And it did get slightly upstream, because it wasn't that everybody was coming to ED. It was that when calls come into an ambulance centre, they had a principle of co-location. So you had an ambulance call handler taking the call, you had a qualified professional police officer to the left, and you had a mental health professional to the right. So as soon as that call came in, they were having a real-time conversation about what do we know about the individual. It was almost like a mini MARAC type discussion, sharing information about what they know, how many calls they'd made, where they'd come to the attention of services, and they make a decision in terms of how do we deploy and respond to that call.
Phenomenal.
Absolutely. So you're getting it upstream, and you're starting to mitigate the numbers then that present to ED, because the right intervention is made from the point of the call.
And certainly the example I referred to earlier, we're starting that within the health family by having mental health practitioners in the NIAS control room. So that's hopefully a helpful basis that we could expand and could do that. It does bring in data sharing and IT issues and all that, but that's something to be worked through. But I think it's incredibly powerful what's been done, even with one trust in one area, without the police involvement. What could be done if actually we had the police involved as well, and we had this across Northern Ireland?
Thank you. Okay, Deirdre.
Yeah, no, thanks for your presentation. Sorry I missed the start of it, but it's just the issue, and I raised this with the police as well, in terms of the right person, right care, and it's the whole governance. And I know it might have been touched on that permanent secretaries are involved. So I think it is important, obviously, to achieve better outcomes, to do the upstream preventative work, because we ultimately know the groups of people we're dealing with, and they're across all of them. They even span into education and into the communities department in terms of inequality and poverty, where it's really entrenched. So we do have to work better together, and the collaboration, that joined up co-design and also co-resourcing, hopefully eventually. And hopefully when we move to 2 and then 3 year budgets, that will start to assist that work even more. It's just around, I mean, the police said there's now the governance and oversight group. So is this work then in terms of, and all the different branches of it that you've been explaining, is that now being built in a more permanent way to the work programmes within each of the departments? And I will be keen, I mean, I agree with your points around this has to become the normal day-to-day work, because sometimes, I suppose like all of us, you're busy and the pressures have increased dramatically since COVID. It's sometimes just fighting the breathing space to think, you know, to kind of think these things out. So it's just what we're doing, I suppose, to train and support, but then also to have that built-in accountability in terms of this work. And my other question leading into more the upstream, just where the, because obviously issues around homelessness and complex lives, where the housing first and complex life work is, obviously with the two departments and also DFC as well. It was obviously signed off by ministers in the previous mandate that that work would begin. So is that work continuing in terms of looking at those wider prevention aspects as well? Thanks.
Thanks. I'll maybe kick off, Peter, if you're happy enough. I think in terms of the governance arrangements, the strategic oversight group that we have, as Peter said, that was mandated by both ministers, so that's a really, really helpful start. So Minister Nesbitt and Minister Long agreed that Peter and I ought to co-chair that strategic oversight group, and that was drawing on the experience from the Cottery Task and Finish group that we also do. In terms of that governance and accountability, I mean, we had our first meeting last week. We met with both permanent secretaries last night, so there's a clear imprimatur at ministerial and at permanent secretary level to make this happen. And we are clear as two departments that right care, right person is happening. It is a thing. So the conversations that we're having at the oversight group is not should we do this or should we not. Yeah. It's how do we do this, and how do we do it in a phased way that all of the organisations that are impacted are in a state of readiness to do it. So that's why it's got to be phased. The terms of reference talk about making sure that collectively we have that shared understanding of what it is we're trying to achieve, which deals with the issue of what we're trying to achieve is the better outcomes for the individual at the end of the call. It's not necessarily just about driving out. It's a, you know, if it drives out efficiencies, great. If it frees up police resources, great, but not at the expense of that person at the end of that call. It also talks about the time frame for implementation, and Ryan's right, we don't have a time frame, and that's a conscious decision that we don't, because it goes back to my earlier point around organisations have to be in a state of readiness. And then it also talks about having that silver operational group, which will do a lot of that heavy lifting to bring up to the strategic oversight group for oversight. So that's kind of how we see the accountability piece operating. Complex lives, I don't have enough detail to speak about on that. I'm more than happy to come back on that, but colleagues might have. Yeah,
I mean, I suppose what I'm conscious of is the work we're talking about today around our CRP and getting the right service, the right support, the right professional dealing with people who need that help fits very much into a number of areas that fall under my broader area of responsibility. So for me, that's the population health, health inequalities. It is about mental health, of which, again, homelessness policy within Department of Health falls within my broader remit as well. So what ultimately my vision for this is making sure, well, at an immediate level, because I have sight of all those different initiatives, I can make sure that they join within the health family, which is no mean feat, I have to say, let alone trying to join it up with justice. But I'm just very conscious that this can, I mean, you're probably all aware, Minister Nesbitt is progressing with the Live Better Health Inequalities Initiative in 2 areas. And we're focusing that very much on areas of high deprivation, and we're using that to try and do some intensive health and social care interventions to make a demonstrable difference. We're starting with health and social care, but that, if you really want to address health inequalities, you're going broader. You're going into DFC, housing, homelessness. And I'm working closely with Grania Long in the housing executive around some of the homelessness work there and the work and the opportunities in that regard. So my idea would be that we start to bring it all in. That's the whole of government bit. It's really hitting the areas that really impact on people's lives. I think the fact that the way we've structured ourselves in the department now, in the Department of Health, allows that join up to happen more, I suppose. There's less risk of stuff falling between the cracks as well, I think, in that regard. So very much aware of it, very much of how this docks into the bigger picture. Use that phrase again.
I might follow up individually, but thank you.
Yes, no problem.
On the back of Deirdre's point there, if I may, I don't know if you folks are aware of Inverary House in East Belfast. The committees, our Justice Committee is about to undertake a visit there. But it's exactly as you say, it's a hostel run by Mindwise. So people there who are homeless, people who have had criminal convictions, people who have struggled with addiction, people who have lost their lives and families, people who had professions and who ended up in a spiral of addiction, lost their employment and so on as a result. And Inverary House is a place where they come into this accommodation. There is wraparound care to equip them to carry on with their lives, stay out of the prison system, the justice system, but also the health system. And it's something that I've been really keen to get Grania Long, the Lady Chief Justice, all of the people in this arena. And actually it might be really useful for the two of you to go and visit that place to see, because actually this place, people in the homeless community, people who are coming out of prison and so on, when there's very difficult circumstances in hostels that can send people straight back, they know if you're allocated to Inverary House, your chances of success are extremely high. So I think that's a real example that could be helpful to you to go and investigate further. Wraparound, getting people back into employment, all of the things that keep people stable, and able to survive in the community without falling back.
Again, that, as far as I understand it, that's the basis of the housing first model. You deal with the housing, and then you start to wrap services around the individual. And as you say, outcomes, Joanne, are just phenomenally better. We're working with Grania and colleagues in DFC around young people leaving care in a similar way. It's a sort of building on the housing first principle of looking at that. Again, it's trying to break it up. I mean, when you look at the whole thing, it's a huge, but we're looking at what we can do for that cohort, which will be very much built on that basis of housing first. But we're always keen to get out of the department and see things.
It might be an option for you there to at least go and check out and see how they're working.
Thank you.
Okay, members, I'm really conscious that Alan, do you have, no, you're just leaning forward. Alan, you're okay? Justin, you're okay? Is there anything else? Anybody? Ciara?
Just 2 comments I wanted to make. Obviously we had a presentation in here last night, just from the youth participation, with the likes of the MAC project and the Simon Community Project for young people, so it's quite similar. Excellent projects, and they're vitally important. Just one question, because I forgot to ask the PSNI. In relation to the Royal College of Emergency Medicine, they're not recommending the move for under 18s. What's your thoughts on that?
Go ahead, sorry.
Nope, sorry, I was happily going to defer to you, because I'm not sure I can answer.
Yes, I don't think it should be excluded, and I can understand in some respects because you have the child protection, you have social services, that's set up. So, has there any decisions been made on that?
No, there's no decision. So again, what that reflects, I suppose, and again, why Mark and I can't speak authoritatively about it. That's why we have professionals there to take their advice, and we slot that alongside everybody else and what their views are, and we'll come to a considered and rounded opinion as to why that is. But clearly they're clinicians, and their views will be quite powerful in terms of why, if that's their recommendation, why that is the case. So we have to take a view as to whether that is appropriate in terms of what's included.
I just think it's really pertinent, and I know the PSNI might come with a breakdown of the stats regarding, we have the number of calls, but we don't have the number of individuals, and a breakdown of the individuals and how many of them are actually under 18. And then if they're recommending the under 18, so to get a kind of drill down into the detail of the picture of the base, to get a baseline, it'd be really interesting to find out. But no, thank you.
If members have nothing else, could I thank you all, first of all, for your patience while we were running late, and secondly, for your answers. I must say, I think this has been a really helpful and a really constructive discussion. I'm relieved, to be honest. I am relieved and really pleased that all of these issues are on your radar and that collaborative working has reached your level, because our fear was that it was much lower down and really these issues weren't being progressed. I think this has the potential to change everything as to how people are treated, and actually for those people who don't fall into these categories, even just for the average person who's going into an NE, I think all of this could be transformative, and I really wish you well with this work, and we look forward to further updates on it. So thank you very much, all of you, for your time, and you're now free to leave. And I'll just
Thank you very much.
Thank you very much, everybody. Thank you.
So members use or not?
Yeah, members, sit your ground. So, just a couple of things for you guys to know. We're no longer quorate in terms of decision making. So we cannot take decisions with regard to future meetings, minutes, any of that. So could I just ask you a couple of things? One is we need to note that the minutes will be agreed by Liz and I. With regard to future meetings, and I think there may well be issues to follow up on, and certainly we've asked for things to follow up on, so there may be a requirement for a further meeting. The committees are no longer, this committee is no longer able to do that. So again, Liz and I and our clerks will liaise in that area, but I can't seek your consent to that because we don't have the quorum, bizarrely. So that is what it is. Can I thank you all for your interest in this regard? Thank you for taking the time. Thank you to those of you who stayed. It's really appreciated. I think this is a great piece of work, and I look forward to working with the rest of you in future. I need DOJ folks to stay a second, please. Literally, it'll be for 5 minutes. But thank you very much, everybody. Greatly appreciated to all the staff involved as well. Very much appreciated. And the meeting is now adjourned. Thank you.
Senate Chamber. Sound. 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 Senate Chamber. Sound.